Okay, we are live now.
Hello.
Welcome,
Yes.
Dr. Kamath, sir.
Welcome, sir.
And we are live now.
Yes, thank you, Abhishek.
Hello.
Hello, Surekha and Rashmi.
Hello. We are going to start now.
A very good evening to all the respected faculties. It's a great pleasure and an honor to welcome all of you to this webinar on hyperglycemia in pregnancy. Today's webinar is in association with Obstetrics and Gynec Societies of South India, Tanjavur, Theni, Tirunelveli, Thiruvannamalai, Trichy, Tuticorin, Vellore, Virudhunagar, Panji, Madgaon, Guntur, Devli, Savangi Obstetrics and Gynec Society, and Vidarbha ISOPAR in association and with help of Corona Remedies. We welcome all of you to this webinar. Let us go to Ma Saraswati and seek her blessing. I request all of you to kindly join for this online inauguration of the webinar. The conveners of this webinar, they are Dr. Respected Dr. Anja Lakshmi Chandrasekhar, Dr. Sampath Kumari Madam, and Dr. Surekha Tade Madam. As we all know, Dr. Anja Lakshmi Chandrasekhar Madam, she is the founder president of TNFOG and has been past president of OGSSI, governing council member of DIPSI. Dr. Sampath Kumari Madam had been vice president elect FOXI, and committee chairpersons of many committees like Adolescent Health Committee, and she is also founder secretary of TNFOG. Dr. Surekha Tade is professor and unit in charge at JNMC Savangi Vardha. She's a teacher, trainer, guide, and mentor since 20 years. Our chief guest to the webinar is none other than respected Dr. Hema Divakar Madam. I would like Dr. Surekha Tade to introduce Dr. Hema Divakar to the House.
Thank you, Dr. Rashmi. First of all, I would like to welcome all the esteemed faculties and the participants to this webinar of ISOPAR Vidarbha chapter with societies from Tamil Nadu and along with TNFOG under the chairmanship of Dr. Anja Lakshmi and leadership of Dr. Sampath Kumari. I would like to inform the House that ISOPAR has been doing these educational activities with various states, and we have conducted these activities with all the South states till now, Kerala, then Tamil Nadu, then we are going to do with Andhra Pradesh, and we have done with Karnataka and Telangana. And we have also conducted webinars in the North, Punjab, Haryana, Uttar Pradesh, then Rajasthan, then in the East, Northeast, the whole area we have covered, Bengal societies we have covered, and we have few more lined up. So our aim is to spread knowledge and in turn gain knowledge ourselves. So that is what we are doing, and we are very much happy to invite Dr. Hema Devakar as the chief guest of today's function. And to introduce her, I think Madam does not need any introduction as such, but formally I must say that Madam is known as a grassroots level worker, especially in the field of diabetes, gestational diabetes. We have seen her all the research work and the community level work she has done in gestational diabetes, as well as her dedicated work in anemia prevention, which we have seen she's working nationally as well as internationally, and through her very focused and very innovative work which she is doing with her organization, that is Artist for Her, which is Asian Research and Training Institute for Skill Transfer. Madam, we know, has given her wonderful years of her youth, and she has dedicated her so many years to Foxy, and she's been the past president of Foxy in 2013, but still we are seeing since that Madam is still going strong as a leader in her field, and now we have seen her internationally in so many organizations. Madam, we are very proud of what you're doing, and we are always following you and getting inspired by the work you are doing. And also I had a talk when we went to the Karnataka societies, we came to know that there, just like ICOG, there is KCOG, and this academic wing of Karnataka is led by Dr. Hema Devakar as the dean. And again, Madam is doing a lot of work in the FIGO PNCD committee, and she's there since 2015 till date. And also now she's elected as the chair of the Well Women Healthcare of FIGO. Apart from that, she has also been doing a lot of work on quality in healthcare, and she's been the convener of Manyata, which is, I think, an influencer in itself in quality, especially in maternal health. And Madam is leading in that front also, nationally and internationally. She has a lot of awards and recognitions from FIGO. There's the Women Achievers Award, Global Asian of the Year Award, and her artist brand has received, Artist for Her also has received the award, and CSR Times of Award for the Devakar Service Trust. So Madam, you have been an inspiration for all of us, and especially I think in high-risk pregnancy, you have been leading from the forefront. So we invite you to guide us on this forum.
Namaste, everyone. And gestational diabetes mellitus is now called hyperglycemia in pregnancy. Why? Because Hema Devakar is hyper about this issue of hyperglycemia in pregnancy. So they changed the name. Just like in the anemia work, they started saying that new equipment or point of care, HemoQ came. They said HemaQ. So that's how. And persistent and consistent efforts is what is required, and that is exactly what Surekha and Rashmi have done today by consistently and persistently cajoling me to come on to being with all of you, my very, very beloved friends. And the topic being a burning topic. Recently, we have finished the Kannada New Year, Gudi Padwa, which is the Maharashtra New Year, and every time we know that what we say in Kannada, Bevu Bella, that is a good and a little bit of neem leaf. So because life is a mixture of both sweetness and bitterness, but we have a large amount of sweetness in the country in the form of a tsunami of diabetes, and the bitter truth about it, which all the leaders here know, and that is why we are here to deliberate. And when we say that the pillars behind this, right from Dr. V. Sheshaya at Tamil Nadu, Anjalakshi ma'am, Sampath Kuwari, Vijay, and the rest of the champions whom I see from Tamil Nadu, the TNFOG, which again and again, we say T. Then they say T for Tanjore. Say no, T for testing. Then they say again T for Teni. No, T for testing. Tirunelveli, no, T for testing. Tiruvannamalai, no, we want T for testing. This is how the society after society after society got sensitized that the first step, Pehla Kadam, is the testing every pregnant woman for the status of her glycemia. And we are so proud of you, Surekha, having recently stepped in, and Rashmi, you too, as office bearers, have bought the Oxy, and many of the teas, not only Tanjavur, Teni, Tirunelveli, Tiruvannamalai, Trichy, Tuticorin, Vellore, and V for victory, I must say, Virudhunagar, Panji, Bhargava, Guntur, and then this shows that geography has no, we don't have the boundaries. You're really making history by bringing so many together. And the point is that we said testing, but what next? That is what is the key to the deliberations as on today, because even in Anemia Mukta Bharat, we say test, treat, and talk. That's exactly what we need to do for all the issues. And how should we do it? Priya, which means pyar se, you to counsel and test everybody. And Komal also means politely. Don't scare them that you got so much of sugars and then this will happen and that will happen. And because somebody was just listing so many maternal problems, so many fetal problems, you have to tell that this is a problem with a solution. And that is how you have to reassure the teams involved in the management of the diabetes in pregnancy, which largely rests on our shoulders. So many attempts have been made to sensitize all the OBGYNs in the country, who are now becoming a role model for the entire Asian and African region. And I'm so very proud of my beloved friends, colleagues, and champions within India who have showcased that where there is a will, there is a way. And gynecologists and obstetricians have primarily taken the responsibility of dealing with diabetes in pregnancy. So we need to know more. We need to do better than what we are already doing. So thank you very much once again for the opportunity, even though it is just, like a chief guest, but the position is not important. The intent with what I have come here is to re-emphasize, resensitize, and make you have a very firm resolve. Don't give up. The next generation leaders like Deepa are here, and they have to get the country moving towards healthy generation next, because healthy mothers make healthy babies and healthy nation. With that, I once again thank everyone for my presence and participation as a token where you are actually bearing the brunt of the responsibility of organizing these meetings with so many societies coming together. That is not a simple task by itself. And congratulations once again. We have Anemia Mukta Bharat, we have Diabetes Mukta Bharat, we have Cervical Cancer Mukta Bharat, and we have the Bharat which is moving towards the pink of health for all girls and women, because they are the ones who have the key to the health of the entire nation. Namaskar, and thank you so very much. Heartfelt congratulations to this whole team, and may you do more, and may we all do better and better. Namaste.
Thank you so much. I think Madam has such a charming personality, and she says the things so innovatively. I think it's like we wish to keep on listening to you and do as you wish. I think whatever you say, we feel like following you and just doing it to the best of our abilities. And thank you for being all that inspiring personality, always smiling and guiding us, madam. Thank you really for joining us. And I think we both of you have been pestering you, so please forgive us for that.
It's called Meetha Dard. So I'm happy. Yeah.
Thank you very much, ma'am.
Thank you, ma'am.
And for your blessings. And we would like to move ahead by introducing our guest of honor for today, which is we have Dr. Priya Ganesh Kumar and Dr. Komal Chavan. And I would like to introduce Dr. Priya, who herself, is a person who is like crusader, I think. When you say diabetes Mukt Bharat, when you say anemia Mukt Bharat, Dr. Hema's name comes in front of us. But when you say cervical cancer Mukt Bharat, then it is nobody but Dr. Priya Ganesh Kumar. I think the kind of work she has been doing, it has been now cervical cancer Mukt Bharat is synonymous to Dr. Priya Ganesh Kumar, who is the chairperson of the Gynecological Oncology Committee of FOXI, medical director of Srinivas Healthcare. And what she is being recognized is for the mentorship and for the training she has been doing all over India for past 2-3 years. I'm following her work as a colposcopist and as a cytology course trainer. In FOXI, she has trained more than 1,000 gynecologists pan-India. I think that's a huge, huge achievement, madam. She's the official master trainer for cancer prevention under NCD Ayushman Bharat project of GOI for the state of government of Madhya Pradesh. She's also a PhD guide at Bharati Vidyapit, and she has lots of awards and recognitions for the work she has been doing in the Thane Gaurav Mayor Award, the National Award, Zee Hindustan Swasthya Award, and from the Economic Times, from IMA, and from also as a Wonder Foxian Awards. Madam, you are really inspirational. I think we now await your words of wisdom for us.
So thank you very much, Surekha. This was too elaborate, no need to say so much. The work which you all are doing, we all have been doing so much. And after Dr. Hema Divakar, why so much of introduction for me? Because Dr. Hema itself is an icon. So definitely, yes, today's program, which you all have charted out through with the Vidarbha Society and TNFOG, itself speaks in volumes. Because what we are seeing today in our day-to-day practice, which we have been seeing since many 3 decades of my practice, see, diabetes is such an important thing. And whenever we have a patient with a diabetes, so we are a little bit stuck, with what exactly to do and when to start and what to do. So the topic itself is very, very good. And the speakers which you have selected are excellent. They are all authors by themselves and positioned by themselves, key positioned by themselves, and authority in the subject. So I'm very happy that you have invited me. Yes, it was a little tiring after AICOG and so much of an activity in AICOG. It was too tiring, but you kept on telling, and that was so sweet of you, Dr. Surekha. And I'm seeing all the societies who have joined very enthusiastically in this program. Yes, knowledge never ends, knowledge is a big ocean. The more you dip into it, you understand that the less I know about it. So it's always better to gota marne ka na, that thing which is there, you jump into the ocean of knowledge, try to get how much we can, because of course we all know that, the knowledge is so vast. This thing is changing, the protocols are changing. Every now and then you see the protocols, FIGO protocols changing, WHO protocols changing. So it is really very difficult to keep a pace with everything. What we would have known and what we would have done would have been outdated. So it's always better to attend such programs. And I'm very happy, Dr. Surekha, you have gone across the state. You have taken with all the societies, and I'm seeing your works, and I am also keeping a watch and seeing. Of course, I didn't keep a watch so much, because utna time nahi milta hai. But wherever I see you have been doing a lot of activities, and all the very best for the forthcoming election, Dr. Surekha. And we wish to see you in the committee chair sooner.
Thank you.
So all
Thank
the
you,
very
Dr.
best for this program.
Thank you, Dr. Priya, and really you're an inspiration for all of us. So there's a saying by Mahatma Gandhi ji that live as if you're going to die tomorrow, but learn as if you're going to live forever. And the personification of this is our next guest of honor, which is Dr. Komal Chauhan, who also has been doing lots and lots of work, especially in the field of medical disorders in pregnancy, as she is the chairperson of medical disorders in pregnancy of FOXI. And since she has taken charge of this committee, we have seen lots of work she has been doing, especially for diabetes and gestational diabetes, especially for anemia, and lots of webinars she has conducted in the pandemic. Also she has taught many postgraduates and trained and coached them, as she has been the honorary professor at R.N. Cooper Hospital. Presently, she is the senior consultant at PN Desai, and also she is the medical director of Chauhan Maternity and Nursing Home. Member of Managing Council of MOGS. We have seen lots of work she has been doing over the years with MOGS, and also in AFG. She's the Joint Secretary of ISOPARB also, and written 2 textbooks, one on hypertensive disorders in pregnancy and another monogram on hematological disorders. So who else than Dr. Komal Chauhan to guide us in this educational activity which we are doing on hyperglycemia? Over to you, Dr. Komal.
Thank you so much, Dr. Surekha. And what I see is real amalgamation. The title, Tour de Tamil Nadu, and I'm really happy that you invited me to this grand tour. It is like amalgamation of so many societies. I can see an ISOPAP where I am also a member coming from. Then your Devli Savangi, that is one Maharashtra society, and 12 Tamil Nadu societies. It's a real great honor to have such a collaborative program. And regards to you, Dr. Anjaliksha, my madam, Dr. Sampat Kumari, madam, they are always there, so active in proxy and really encouraging and getting together all the South India is in the revolution. What I can see under their leadership. And Dr. Rashmi Kar, who is the Joint Secretary of ISOPAP Vidarbha chapter, thank you so much. I am really congratulate you for having a focused program on hyperglycemia in pregnancy. When as a chair of medical disorders in pregnancy, what we need to really, go out and talk about is hyperglycemia, because so many things are newer, things are coming, changing. The screening, which has to be really universally accepted and it has to be promoted and spoken upon. Every corner of India should be knowing about screening. What are the correct methods of screening? Because there is a lot of guidelines. WHO guidelines talks one, DIPSI will talk another. What is good for Indian scenario? No, we need to know all that. So if it's spoken on this platform like web programs in which all the societies meet and some common viewpoint practice points are given, so it becomes very good for our clinicians to practice. And definitely this is an honor. I really want to say that to share a platform with somebody like Dr. Hema Divakar, when as a committee chair, when I think of hyperglycemia in pregnancy, the first person in India which comes into my mind is Dr. Hema Divakar, and a very, very like the able person who has guided us in this hyperglycemia, in diabetes, how to encounter, what are the difficulties, what are the screening, and Madam has spoken so much that how important it is, to take forward that when we do anemia mukta or we do diabetes mukta or any programs, these programs need a lot of emphasis and they had to carry forward. So I think that you, Surekha, and your team, everybody are carried forward in this very, very aptly, and wish you all the success for your future, whatever you are aspiring. I think you are really, really doing very hard work and you're most deserving in all aspects. The topics which you have chosen today are really going to cover hyperglycemia in pregnancy as a whole. right from pharmacology to screening protocols, then cases and practical points. Today, I was just seeing some posts of the Diabetic Association. They are now coming up with a tablet, peptide tablet. Some revolution in technology is happening. We know diabetes, we know the actual treatment is always insulin, but lots new is happening, and I think we need to hear more and more about this topic, about diabetes in general, in our pregnant women and everything. So all wish you all the best, and all faculties are very, very excellent and at par. And I'm really very happy and congratulate you and wish you all the success. Thank you so much.
Thank you, Dr. Komal. And definitely, I think we are going to have a comprehensive knowledge of hyperglycemia as a whole and pregnancy, especially as we have Dr. Lakshmi Sheshadri and Dr. Sampath Kumari to guide us as speakers and wonderful panelists. We have Dr. Anjalakshmi, who is the expert. And we would like now to take forward the academic session. And I invite Dr. Rashmi to introduce our first speaker, Dr. Lakshmi Sheshadri, who is joining us all the way from US, as and probably it is 4 a.m. or 5 a.m. in the morning. So thank you very much, Dr. Vijay Lakshmi, for joining. Rashmi, please introduce our chairpersons.
Thank you very much, Dr. Surekha, madam. Let us move to the academic session. The first talk is screening protocols in hyperglycemia in pregnancy. And the chairpersons for this session are Dr. Shailesh Kamath and Dr. Uma Shankar. Dr. Shailesh Kamath he is the president of Panji Obstetrics and Gynec Society. He is a private practitioner since 1996. He has been honorary secretary IMA Mormugaon 97-99 and organizing secretary IMA Goa State Conference. He also has been organizing secretary Indo-Swedish Traveling Seminar. He's honorary secretary Panji Obstetrics and Gynec Society 2000 to 2002. He has been organizing secretary Pashchim 2001 Best Zone Foxy Conference and convener for Goa First Foxy Satellite Conference 2004. It's a great honor and a privilege to have Dr. Shailesh Kamath as a chairperson for this session. We welcome you, sir. Our next chairperson for this session is Dr. Uma Shankar. He is clinical head and infertility specialist, Ahilya Hospital, Guntur, Andhra Pradesh, and joint secretary in GOGS. And he is secretary APOGS, executive member in AP-ISAR, and organizing secretary with HIP APCOG. We welcome you, sir. And I would like to hand over the session to our respected chairpersons.
Thank you, madam. I'm Dr. Shailesh Kamath here, and I bring greetings from Goa. Greetings to all these.
Yeah.
You can hear me?
Yes, sir, please.
Yeah. Greetings to all the faculty members. Thank you, organizers, for having this wonderful webinar. And thank you for giving me this opportunity to chair this session. If you could.
Can we have Madam CV?
Yeah, if you could.
Vijay Lakshmi, ma'am. Yeah.
Madam Vijay Lakshmi Sheshadri. She is senior consultant at Sundaram Medical Foundation, Chennai. Past president of OGSSI, executive committee member, Tamil Nadu Federation of Gynecologists, member, practical obstetrics committee, FOXY, past Chennai chapter secretary of IMS, constitution committee member of ISOPAD. She has won best paper award at AICOG 2014, been treasurer of AICOG 2015, chairperson research committee for 2018 to 2020. Special area of interest is high-risk obstetrics and midlife health. And today she is going to enlighten us on screening protocols in hyperglycemia in pregnancy. Dice is yours, madam. Let's start.
I'd like to inform the August audience that we have been reading Madam's book since ages. I think I have been also reading. So thank you, Madam, for all the academic work and scholarly work you have done in the field.
Yes, really thank you, ma'am. It's really on the table always.
No, this is not me actually. This is Lakshmi Seshadri. I'm Vijay Lakshmi Seshadri. Lakshmi Seshadri is from Velur. Okay. So, good evening all. Can I have the share screen? In fact, can I share the screen, please? Yeah.
Madam, are
Hello?
you able to share screen?
Yeah, I'm able to. Are you able to see?
No, madam, we are not able to see. Could you share it from your side?
Yeah, I am sharing it.
Right.
1 second, just hold on. Just 1 second. Yeah, I'm sharing. Oh, I'm sorry. 1 second, just hold on. 1 second.
Dr. Anjalakshmi,
Yeah,
madam?
yeah, 1 second, 1 second.
Yes,
I
madam.
opened the
You can take your
presentation.
time till that time. Yeah.
Yeah, 1 minute. 1 minute. Sorry about that. Share screen. Share screen. Share screen. Host the open button. They say host has disabled participant screen sharing.
Okay, Abhishek, please allow.
No, there is no restriction. I will check the. Please check, ma'am.
Yeah.
Please check again, ma'am. If you can share the presentation to me, madam.
Yeah, 1 second.
Yeah. Just send it to me on mail.
Yeah, 1 second. Just sorry. Is it coming now?
Yeah. It will. Yeah, ma'am. Just make it full screen, ma'am.
Yeah, I will do that. Yeah. Is that okay now?
Yes, ma'am.
Yes, we can see.
Yeah, but my photo. Okay. Am I audible?
Yes.
Yes, ma'am.
Okay. Thank you. Yeah, sorry about that. So, good morning, everyone. And at the start, I would definitely thank Dr. Surekha for giving me this grand opportunity. Though it takes a couple of minutes to thank everyone, but it is important. And to share the stage with eminent people here like Hema, of course, a very good friend of mine, but it's always a pleasure to see her share the stage with her. And of course, Dr. Anjalakshmi madam, who has been, I would say, as far as we are concerned, we think of hypertension, hyperglycemia in pregnancy, and we think of madam all the time. And in fact, my presentation would be short, focused only on the screening part of hyperglycemia. But I know all these expert people here, along with Sampath Kumari and Komal, everyone will be able to give in more inputs, and definitely I would be learning a lot from this webinar. That's what I'm looking forward to as well. Thank you, Surekha, for this wonderful opportunity. And in fact, I'm a little jittery to even talk about this topic, which Anjalakshmi madam and Hema has been working on for years and years. And I know they would be really be able to summarize this with lots of inputs at the end. And here on, I move to say that when I was asked to talk about the screening of for HIP hyperglycemia in pregnancy, always whenever we talk of screening, most important questions that we need to answer all the time is it, why do we even talk about the screening? and whom are we going to subject for screening, and when exactly can we do this screening, and how are we proceeding. And as Komal said in the beginning, as all the experts told, that the scenario is changing, whether we are moving towards a simplified procedures so that it is reachable to everyone is all the time very important for screening purposes for any particular medical disorders. And of course, this will all be based on years of input from facts, the evidence, what are we trying to achieve by screening the population, and of course, the impact that has. And ultimately, we need to arrive at consensus. As things go on, there are multiple opportunities for doing. Of course, it gets subject to the population that we are trying to focus on. And always we know it needs to be very sensitive, very specific. Both of them may not always combine. A highly sensitive test may not be really very specific, but then we need to arrive at least about 96%, 95% sensitivity and specificity. Of course, it needs to be affordable. Otherwise, it is not really going to be applicable to most of the population, and it should be user friendly, should be able to get accepted by the population that we are exposing to, and of course needs to give consistent results and needs to be a reliable procedure. So whenever we talk of a screening method, it needs to be very, very perfect in every way that we may not be able to achieve. But luckily with hyperglycemia, so much of tremendous work has been going through for years and years, and still we are not able to get a good hold on it. But as Hema said, maybe in years to come, India should be really able to, although nowadays we say it's a diabetic capital of the world itself, but then from years now on, probably by screening methods and then a perfect management, we should be able to get a good control of the diabetic status in pregnancy. Now we know the global burden is 7% of all pregnancies, which itself is not very low. But in India, it is even greater, 12 to 20%. All these expert practitioners here, we all know every third, fourth patient that we see in the OPD comes on with hyperglycemia at some stage of pregnancy. And it definitely gives a big impact on our practice, and to see them through without complications and without issues. And more importantly, that we know that pregnancy is such an important susceptible state for the development of diabetes because of lots of physiological issues that we are all aware. I'm not going to go into any of those details because we all understand how pregnancy becomes so very susceptible to the development of the diabetes. And more importantly, it's an inheritable problem, and therefore it carries on through generations, and therefore it goes on and on. The trend of obesity and physical inactivity being on the rise is further causing rising incidence of the hyperglycemia. And again, it's very important that we stay focused despite so many medical disorders which happen with the pregnant state. This is also very important. The effective screening and monitoring of for hyperglycemia is a big step forward, which has gone through lots of revelations. And of course, that is very important when we see that the pregnancy needs to be struck at the beginning so that the fetal anomalies and the glycemic issues of the fetus doesn't take over, and the long-term maternal hyperglycemia with its own impact on the mother doesn't happen. The labor complications are, of course, very many. We know, starting from the shoulder dystocia to difficult labor to increasing trend of the cesarean section for the diabetic state in pregnancy. And therefore, it's definitely there is no need to even ask this question, why are we screening for the hyperglycemia in pregnancy, which is very important, and we definitely need to make it ahead. Now, any degree of glucose intolerance, which is first discovered during pregnancy, first recognized in pregnancy, is called as gestational diabetes, but we know we have moved away from this definition itself, encompassing more of the hyperglycemic status in pregnancy. And now, as we all know, it's now the hyperglycemia in pregnancy. And the worst part of it is it leaves, of course, apart from the fetal issues, a pregnant mother landing on into a diabetic state even years after the pregnancy. And the insulin resistance and the placental diabetogenic hormones during pregnancy make it so very susceptible that her entire metabolism changes into a diabetic susceptibility. Now, the screening for this hyperglycemia starts quite early, we know, but then do we present all these mothers to a selective screening based on their history, on the risk factors or the clinical presentation, or do we go ahead with the universal screening? We all understand that when we subject for the universal screening for these mothers, it is all based on the population and the availability of the logistics, the lifestyle modification, diet, and the genetic makeup we always keep talking about, but how much are we able to achieve in person with every patient? It is so very difficult that we keep on addressing these issues, but the lifestyle and the diet pattern doesn't really go very strongly into the mind, and the hyperglycemia continues. The genetic makeup is one which subjects the Indian population so much into this hyperglycemia, and therefore if risk-based screening alone is done, maybe we will be missing almost 50% of these hyperglycemic states in pregnancy. And therefore, when we talk about a selective screening or an universal screening, it has to be based on the population that we are subjecting them to and based on their clinical presentation. Quite often, they may not be really presenting with a full-blown symptom of the diabetic state, and therefore, we need to really subject them to the screening and pick them up very early. Now, the risk factors, though we have a lot of them, we are all aware of this, that the Asians in particular, we are very, very susceptible, but then all over the globe, the risk factors continue. The BMI more than 25 is a well-known factor. Weight gain after the adolescent age is also a very big factor. Physical inactivity, we know in this computer era, in the technology era, it is not hard to believe that the physical inactivity is increasing. A past history with the GDM, macrosomia, fetal loss, and a diabetic person in the first degree relative, and of course the maternal age being more than 35 and weight gain is all correlated with the hyperglycemia in pregnancy. So of course, these risk factors we are keeping in mind all the time, but then can we restrict only based on risk factors for the Indian population? And as I said, if we do that, we may miss even 50% of these incidences of risk factor of hyperglycemic states. Now, screening for the hyperglycemia starts well ahead. Ideally, we should start a planned pregnancy. We should be able to do it even before pregnancy, but then that does not happen in the routine. And most of our population come to us with the initial visits. Luckily for us, I would say, over the years, we have come to an era where people come ahead right when their urine pregnancy tests are positive or when they are anxious about their early pregnancy. But those were some days ahead when we definitely never had a first visit coming up very early. But it is very important that we pick them up early, and therefore an early initial antenatal visit is important. Of course, a little in the rural side or a little away from the main centers, we still have patients coming up presenting us a little late after the diagnosis of pregnancy. The frequency or the repeat screening comes on as the monitoring after the initial screening, which moves on to the diagnosis. And we all know that the fetal pancreas at 9 weeks itself, the insulin is detected, and the maternal hyperglycemia increases the fetal pancreatic beta cell mass, and the hyperinsulinemia can be detected right at the 16th week. And hence it is important, keeping this factor in mind, it is important that we pick up the overt diabetes group in the antenatal visit with the early pregnancy itself, and or if we miss at least at 12 to 16 weeks. And then once this is detected or not detected, we move on to the 24 to 28 weeks when the next screening phase comes on, and 32 to 34 weeks is again a period when we need to move on with the next screening phase so that we don't miss them out at the time of labor. And hence, although we do have these weeks presenting to us, many a times these may get missed, and it is an important duty for us to pick them up at least at these stages, talking of the screening for the hyperglycemia itself. Screening, how glycosylated hemoglobin more than 6.5%, they say, is of course very easy to pick up, and we all know. And if we start the pregnancy with this kind of a glycosylated hemoglobin, even higher than this, we are all a little jittery till the anomaly scan comes on, because we know it can have a higher incidence of the fetal anomalies. And blood sugar levels, of course, the full backbone of the screening and monitoring as well through the pregnancy. And again, venous or capillary blood sugar levels can be done. For easy access, of course, the capillary hyperglycemia is enough, but definitely a venous sample is a better test anytime. Again, can we do a fasting level, or do we have to go on for a postprandial or a random, or do we give a glucose challenge, and by way of glucose challenge test or oral glucose tolerance test? And we have 50 milligram, 75 milligram, 100 milligram of glucose to give as a load. Do we go ahead with a single test or a one-step test or a two-step test? All these come into our mind whenever we talk of a screening for the hyperglycemia in pregnancy. And as we move on, we will come to a consensus where what applies best for our population. Although there are lots of academic bodies which stick on to different protocols for the screening, but what applies to India is important as an obstetrician practicing in India as well. And therefore, we will try to sort out these as a methodology for the screening of hyperglycemia. As I said, there are different bodies, the diabetes in pregnancy in the study group in India, the FOGSI, the American Diabetes Association, the American College of OGs, the World Health Organization, the International Academy of Diabetes, the NICE guidelines, the US Task Force, the Canada Diabetic Association, all have varied opinions on the screening protocols, and still they all have their follow-up protocols. The HAPO trial, which was done in a huge way, gave some inclination towards the index score, where they said that perhaps just detecting, it doesn't even matter what is the intensity of the hyperglycemia. Hyperglycemia itself causes lots of obstetric outcome difficulties, and that gave a lot of input towards the screening protocols. The UK forces, the national health policies, all these were tried from time to time, and therefore the protocols kept changing. But what is important today, are we going to follow the single test, which means whether the patient comes on the fasting or the non-fasting levels, the oral glucose is given as a challenge, and at 2 hours we take for the threshold value and see whether it is a screen positive or not. And this is as this single test, which I will be talking about a little later as well. The one-step test is where the patient comes as a fasting, in the fasting state after about 8 hours of fasting, and the glucose levels are measured. Then 75 grams of the oral glucose is loaded in, and the values are taken 1 hour, 2 hour, and the glucose levels are then put across the threshold value, and if it is more, we take it as a screen positive. Now, when we move on to the two-step test, it's like a non-fasting, and 50-gram oral glucose is given as a challenge, glucose challenge test, and if that is positive, then we move on with the fasting glucose level, and then a load of 75 or 100 grams of oral glucose with sampling at 1 hour, 2 hour, 3 hour glucose levels, and any two values more than the threshold values will show screen positivity. And this is two-step test. So whether we can take it as a single test, a one-step test, or a two-step test is again based on the individual choices and the population that we are exposing. It is not again difficult to understand that early in pregnancy, when the patient presents to us, we do go ahead looking at the risk factors which can expose. But in a country like India, as I said in the beginning, that the risk factors alone is not important. Whether there are risk factors or no risk factors, we subject to them to an early screening, and then in some population where the incidence is low or some associations that follow, they do not take the early screening if there are no risk factors and subject them straight away at 24 to 28 weeks. But take them at the beginning for screening, then either whether we take a two-step, one-step, or a single test, and then if it is negative, again move on to the 24 to 28 week screening. But if it is positive, we right then, because it's an early pregnancy, we should be thinking of the overt diabetes, and there again HbA1c will come handy. And if, because many of us we know don't go through a planned pregnancy, and therefore the diabetic state might not have discovered, or even they are blinded, they do not really think about this state before embarking on pregnancy, and therefore a overt diabetic state can be discovered. Once the screening is done, and we move on, in case they are confirmed diabetic or confirmed hyperglycemic at this stage, we move on with the management, which we will be hearing in the next talk as well as in the panel discussion. I'm not going to touch upon the monitoring of these diabetic states, because again, I will focus to screening alone. The screen at 24 to 28 weeks, if there is a negative screen at the early visit, then we move on at 24, 28 weeks is important. And because we know the pregnancy influences start coming up and showing up at this weeks, and therefore it is important not to miss this week of gestation, move ahead with the screening at this stage. If it is negative, the routine care goes on, and again we try to pick them up at 32 to 34 weeks for a diabetic hyperglycemic state. Again, if there are some symptoms intervening, we definitely can expose them to the glycemic screening, and we can move on with the diagnosis. But if it is a positive screening, then at this stage, again, they are declared as hyperglycemic, and therefore, again, we subject them to the close monitoring, the dietary restrictions, the lifestyle management, and of course, the pharmacotherapy and other management for both the mother and the fetus to avoid the obstetric complications. So this is how we move on, and it is, I'm sure, is not difficult to understand at all how we move ahead with the early screening and then keep picking them up with regular antenatal visits. The threshold values have been set by different academic bodies, by different interventions, and that diabetes in pregnancy study group in India with the FOXI and the Ministry of Health and Family Welfare India has approved the single test. And we are really at this background, definitely I cannot forget to mention Professor Padma Shri Seshaya, who has worked all through and has brought this into the ambit of FOXI, as well as I got a full approval with the Ministry of Health and Family Welfare and the Maternal Health Division of India. The single test means the patient comes, doesn't matter whether fasting or non-fasting, subject them straight to 75 mg of glucose orally and in 300 ml of water. She has to swallow that within 5 to 10 minutes. And if the readings come as 140 milligram per DL at the end of 2 hours, and that is about 7.8 millimoles per liter. So this is at the 2 hours that we test after the 75 milligram challenge, and that becomes positive or negative as an important screening test, so very easily applicable to any population. If vomiting occurs within 30 minutes, it's important that we abandon the the test at that time and then repeat it the next day. So this is important screening test which has come on. Now, the WHO continues to say that fasting levels can be with 6.1 millimoles or 110 milligram per DL, and 75 grams glucose can be challenged. And at 2 hours, if these are the readings of less than 120, 120 to 139, 140, we give them the different brands of the hyperglycemic state. And 200 and above directly takes them to the diagnosis of full diabetes. So even in this, with the single test, though this is a screening test, we can give the same for the monitoring as well. And anytime the patient presents to us as for the hyperglycemic monitoring, or after the returning screen negative for a repeat screen test, it still applies that we give them the 75 mg, follow them up at 2 hours. If it is more than 140 milligram, we take it as positive. And of course, these levels of more than 140 for the, for above 200 for diabetic state is important. So these, even after all these levels, we can definitely remember at least one test and one level. The International Academy says that for fasting level more than 92, that is 5.2 millimoles, and 75 grams of oral glucose can be challenged, and at 1 hour and 2 hours, 180 and 153. And any two of these readings, if they show positivity, we take them as the screen positive. The American Diabetes Association lingers on almost the same levels of 10 millimoles and 8.6 millimoles for the 1 hour and 2 hour after the 75 gram glucose tolerance challenge. Now, the American College of OG, instead of 75 grams, moves on to the 100 grams, and they stick to it. And most of the American bodies are mostly on the risk-based screening because of the relatively lower incidence. But of course, nothing stops them from looking at the screening protocols, at least for the Indian population, or at least for the Asian population or the Native American populations, for the early screening protocols for the early pregnancy. But if risk-based screening is followed in America, in the Australia, and of course, according to the NICE guidelines as well. So screening for hyperglycemia in pregnancy, we need to arrive at consensus after we have discussed everything about it, about the protocols, about this. I think at present, we can easily stick on for the screening purposes and even for further monitoring based on individual choices and the population that we have with a high risk group. They would fall into one of the risk groups anyway, and they have a high possibility for developing hyperglycemia in pregnancy. We will go ahead with the universal screening. Pick them up early in the first antenatal visit. If we miss it, 12 to 16 weeks, and if still they are negative, or if they are missed at 24 to 28 weeks, 34 to 36 weeks again for a follow-up, so that we could plan the protocols for obstetric management well ahead and prevent the fetal problems, and of course stick on to good obstetric management, which again I will not be covering in this talk. Now the single non-fasting level, give 75 gram, pick them up above 140 mg/% at 2 hours. Of course, a pre-pregnancy is a very good counseling that should go on, and that will come probably. It's also our responsibility to see that once this pregnancy ends, we stress on well for them to not forget this diabetic state and go on for a postpartum check at 6 weeks. Recently in US, they have moved to even 4 weeks for those who have hyperglycemias in pregnancy. And then if postpartum, they are well under control, of course, depending on the levels, we can move ahead with every 1 to 3 years of monitoring. I'm sure all the eminent people on the stage today will be able to give us more inputs, but it is important as an obstetrician's responsibility that we stress on the pre-pregnancy. If at least we don't, then move ahead for the post-pregnancy check, so that, because we do know that many of them land in a diabetic state for life, and they are going to get exposed for this even in the next pregnancy. So thank you very much for this wonderful session, wonderful opportunity, and I'm really happy to be sharing the stage with you all today. Thank you very much.
Thank you, Dr. Lakshmi. And Shailisha and chairpersons.
I'll stop share.
Thank you, madam. It was a nice, elaborate lecture. You covered almost all topics. Why we need universal screening, what stage to check, which test to use. I remember the days when we used to do full-fledged oral glucose challenge test, and then patients wouldn't be willing to undergo the test for the logistics itself. And so many cases were missed. But today, thanks to research, as you said, by Dr. Sechaya, and all the participating people, we have a very good test in single 75 grams glucose challenge test. And we owe it to our future generations. If diagnosed in time, treated in time, maybe in years to come, we will not have India labeled as diabetic capital of world. Thank you, madam. Thank you so much. Thank you, organizer.
Thank you, Dr. Shailesh. And can we hear from Dr. Umashankar, please, for the concluding remarks? Dr. Umashankar is there?
Hello.
Yes. We are
can
able
hear me,
to
madam?
hear you, but not able to see you.
Yes, ma'am. The recording video is not good. Madam, there is
Okay.
just one thing I would like to request, madam. What is her opinion on COVID and the GDM? Is there any explanation you would like to give for screening if you have past history of COVID? Because we are seeing a lot of diabetic cases in COVID. I would like madam to just enlighten this little bit.
Dr. Lakshmi, are you able to hear?
Yeah.
Yes, ma'am.
COVID definitely has increased the hyperglycemic susceptibility. But some of them have, in fact, probably we will say it has uncovered some of the diabetic states, probably. But then long term, if they are during management in pregnancy, in COVID, of course, with the COVID, we do have a challenge with, we all know that it's hyperglycemia, which is going to increase. But personally, in person, I never had a patient during this stage who was also hyperglycemic and COVID inflicted. Maybe we can hear from Anjalakshi ma'am and Sampath. Anjalakshi ma'am. So
Madam,
definitely
please unmute yourself, ma'am.
Yeah. Anjalakshi ma'am, unmute yourself, ma'am.
Yeah,
Madam
Sampath
is not
Kumari,
able to yes, madam is not able to unmute. I think in our Institute of IOG MMC, we had lot of cases as during this COVID time. Because of the COVID, yes, Anjalakshmi madam has been there. Yes, madam.
Actually, during COVID time, in Institute of Obstetrics, they stopped screening for GDM.
Yes.
They gave preference for the clinical status of the patient and improvement. So they stopped, but it was very easy to screen even in the COVID time, because you can ask the patient to take 75 grams of glucose in water, and every patient, when they come for a scan, this test can be combined and it can be done. And the COVID as such did not increase the incidence. Only thing, they did not do the test in the institutions. That was the situation. Now again, they started doing universally, screening universally.
That time there was no routine OP, madam. That is the reason. We had only casualties.
Right, ma'am. So the COVID pandemic really affected the access to care and the institutional care which the women should get. That was affected, and probably that affected the testing and the screening also. Not only in diabetes, but so many other medical disorders and so many other services were also affected. So I think what Dr. Uma Shankar was asking was whether COVID affected the COVID as such affected gestational diabetes status. I don't think so, but maybe the type of the steroids which we were giving as management, maybe that would affect the overall incidence. I think that should be a sort of a research in itself.
Probably more of uncovered.
Actually, we analyzed the number of cases both the years 2021 and 20, and there was not much of a gestational diabetes. Okay.
Right, ma'am. Okay, thank you so much, ma'am.
Statistics and analyzed that.
Right, ma'am. Thank you so much, ma'am, for that information. And we move ahead with that to the next session. And thank Dr. Sampath Kumari, madam, for not only agreeing to be the speaker for this session, but for the collaboration with TNFOG, which we could have and which we are really happy to be collaborating. Thank you so much.
Because of Dr. Anjalakshi, madam.
Thank you.
Because of her only.
Rashmi, please go ahead.
And Sureka, in this time, I also want to tell you that this is with TNFOG. Oxy has not involved. Only we have come as speakers and chairperson. Okay.
Okay. Right, ma'am.
Okay.
So moving ahead to next talk, it is by Dr. Sampath Kumari, madam, respected Dr. Sampath Kumari, madam, and it is on pharmacotherapy in hyperglycemia in pregnancy. The respected chairpersons for this session are Dr. Radha Madhvi, madam, Dr. F. Dorius, madam, and Dr. Venkateshwar Rao. I would like to introduce our respected chairpersons to the house. Dr. Radha Madhvi, madam, she is the founder president, Thiruvannamalai Obstetrics and Gynec Society. She is the director at Rajam Multi-Speciality Hospital and director of Rajam Institute of Paramedical Sciences. She is the joint secretary and executive member of TNFOG and member of FOXY, ISAR, and IMS. I welcome you, ma'am. And next chairperson for this session is Dr. F. Dorius Einstein, madam. Madam is consultant obstetrician and gynecologist, ABM Hospital, Tuticorin, and is at present she is the president of Tuticorin Obstetrics and Gynecological Society with special interest in high-risk pregnancy and laparoscopic surgery. And next chairperson for this session is Dr. B. Venkateshwara Rao. Sir is President, Guntur Obstetrics and Gynec Society and Professor HOD OBGYN, Guntur Medical College. And his special areas of interest are high-risk pregnancy and infertility. We welcome you to the session, sir. I would like to hand over the session to our respected chairpersons.
Radha Madhavi, ma'am, you are on mute. Please unmute yourself.
Please share this slide of Dr. Sampath Kumari, madam. Abhishek.
Good evening, everybody. It is a great privilege and honor to introduce Professor Dr. S. Sampath Kumari, MD, DGO, FICOG, FC Diabetes, FIME. She is like a guru to me in this whole journey in Obs and Gynae. She is Chief and HOD, Muthukumaran Medical College and Research Institute, Chennai. FOXY Vice President elect 2022, Founder Secretary TNFOG, National Correspondent Editor, Jogi 2124, Senate Member Tamil Nadu Dr. MGR University 2124, Chairperson FOXY Adolescent Health Committee 2016-2018, Deputy Director and Professor OG retired from the prestigious IOG Madras Medical College, President Board of Studies, OG Tamil Nadu Dr. MGR Medical University 2015-19. Member Board of Studies, OG Meenakshi Medical University. ICOG Governing Council Member 2015-2020. Welcome, Madam.
Thank you, Dr. Radha, for the nice words. And first of all the best to Dr. Surekha. And I thank the organizers for the wonderful opportunity and involving the TNFOG. With again 10 societies of TNFOG has been involved, I think.
Yes.
Yes, I will share my screen. 1 minute. Yes, can you see my screen?
Yes, ma'am. Please go ahead.
Thank you. Dr. Rashmi, the Tiruvannamalai, it is one Ishwar temple. Very, very famous. Once you should come to Tiruvannamalai, Rashmi. Okay, it's very powerful.
I will for sure, ma'am.
Once Surekha's results is announced, you come with her.
Madam, I will be in Salem at that time, and probably I'll be able to meet all of you.
Yes, sure. So now we had a wonderful talk by our past OXI president, Dr. Vijayalakshmi Seshatri, about the screening. Now we will go to the management. So what is that HIP, hyperinsulinemia in pregnancy, is that pregnancy itself is characterized by hyperinsulinemia and insulin resistance, because pregnancy is the diaptogenic. And there is 30% of increase in insulin secretion to compensate the insulin resistance. So what is the pathophysiology? Normally, this fetoplacental hormones, growth hormone, cortisol, that is the reason we were talking about the COVID situations, whether it has increased or not increased, that is because of the steroids. And this leads to the increased insulin resistance, which leads to compensatory increase in insulin secretion, which is in normal pregnancy. If not so, it leads to the GDM. So it is the lack of insulin secretion, which is the cause for the GDM. So what are we going to do? As Dr. Vijay Madam told, we have screened. Now the universal screening is the important thing, and we have screened and we have diagnosed as GDM. So what happens with the when it is screened, and if we have diagnosed as a GDM case, normalization of maternal blood sugar level from the day of conception to the day of delivery and 42 days after delivery, that is 6 weeks. Prevention of obstetric complications by good prenatal care, that is with the monitoring. With that only we can reduce the obstetric complications like hydramnios, PAH, whatever deadly complications during the delivery. And the early detections and the prompt treatment of diabetic complications. So only if we diagnose and identify the macrosomia, only we can avoid the PPH and injury to the genital tract. So whatever may be these complications, it has to be identified earlier. Careful timing and appropriate mode of delivery. See, for a 4.5 kg baby, if you are not identifying and go for vaginal means, it will be a problem. So careful timing when it has to be. If the sugar is not under control and the patient is getting the insulin of the high doses, means it has to be terminated earlier. So the timing and appropriate mode of delivery is very, very important. And the intensive neonatal care, that always previously used to take blood from the cord blood itself. Nowadays they took blood after an hour. Follow both the mother and the neonate to avoid the complications. To avoid the complications, the patient should be in the euglycemic control throughout. So how are we going to prevent this complications? Only with the insulin, that all of us know. But educate the patient. Dietary and exercise recommendation, self-monitoring of the blood glucose, self-administration of the insulin. Previously, all patients were little afraid how to inject the insulin. Nowadays, all are well versed. Even whether it is rural or urban, they know how to inject the insulin. And the treatment of hypoglycemia, this also, it is very, very important. When the patient is on insulin, you have to tell her the hypoglycemic signs, what will happen and what she should do. At least the family also should know this patient is the GDM and she may go for hypoglycemia at any time also. And the physical activity. Nowadays, all of us very well knew that the patients, once they become pregnancy, means they think that it is a pathological phenomena. And they want to take bed rest and they don't want to do exercise. This has to be counseled to them. So normal household activities, at least they can do, and half an hour, 5 minutes walk in the morning and evening. That physical activity is very, very important. Always I used to tell that diet and exercise should start from adolescence, not only from the pregnancy. From the adolescent, if you take care only, we can reduce the incidence of GDM. And to reduce the stress, always nowadays we have yogas. In our Madras Medical College Institute, we have the yoga separate OP department next to the regular OP department. So all patients coming for antenatal in batches, they will be sent for the yoga class. In this way, they can reduce the stress, and care should be taken to minimize the anxiety that is because of the stress. So how are we going to treat this hyperglycemia? Once we have diagnosed hyperglycemia, it should come to the normoglycemia. What will happen? With the screening test, as madam was explaining, if it is only 140, 145, there we can go for MNT, medical nutritional therapy. And if it is not controlled with the medical nutrition therapy and the value is very high, as she mentioned as 200, then only we go to the pharmacotherapy of insulin preferably. Insulin is the golden treatment for GDM. So the maternal glycemic control, maternal blood glucose monitoring, this is with that is very, very important. And then the fetal hyperinsulinemia control, we have to monitor with the ultrasound parameter. So maternal glycemic control will be monitored with the blood sugar value, fasting and postprandial, one day in the morning and the next week in the afternoon, next week in the night, before and after the food. And the fetus conditions will be monitored with the ultrasound abdominal circumference. This is the reason after 28 weeks, every 4 weeks, we do the ultrasound to assess the hydramnios, to assess the macrosomia baby. So fetus is monitored with ultrasound and maternal health is monitored with the blood glucose level. This is the normal, just an identification. If the sugar value is with 100 to 150 means there can be the perinatal mortality, whatever can, if the sugar value is 200, mortality or morbidity, this has to be kept in mind. So once we diagnose what is the medical nutrition therapy we are going to give, always we know that the weight gain during pregnancy is 300 to 400 grams per week. Total weight gain is 10 to 12. But if the patient is obese and overweight, it can be reduced depending on the BMI. So the calorie requirement is very, very important during GDM. So CHO, 50 to 60% of the calories from the carbohydrate, and protein should be in the value of 1 to 1.5 grams per kg, and the fat remaining around 20%. Why I am telling about the medical nutrition therapy means once it is not controlled with MNT only, we go for the pharmacotherapies, that is with the insulin. So the breakfast is very, very important. Always we should stress upon the taking the breakfast immediately. Once they get up within 1 or 1.5 hours, they should take up the breakfast. And the breakfast also, it should not be taken with the large quantities. If needed, it can be split into two. At 8 o'clock, some 2 idlis or whatever it is, and after 1 hour, another 2 idlis. So if they are not, it should be taken in the large amount, and it can be split in the 2 states. The exercise, not the vigorous anaerobic exercises, walking half an hour, not even half an hour, morning 10 minutes, afternoon 10 minutes. And the ergometric, some exercises. And the swimming can be allowed if the patient is willing. Otherwise, we don't need to advise. If the patient is willing to do that also, for the reason of a pregnancy and GDM, there is no need for restriction to the swimming. So the diet and exercise is very, very important. If the sugar values are not controlled, once we have controlled, GCT has been done, and the sugar value is more than 140 means, we will repeat as madam told about the screening. And we, after once, if it is a positive with GCT means, we will monitor with the fasting and postprandial. If it is not less than 140 only, we will do the GCT second trimester and third trimester. So we have to monitor with the fasting and postprandial. Fasting should be less than 90 and postprandial should be less than 120. So once the patient is advised for medical nutrition therapy, then repeat the fasting and postprandial after 3 days or weekly, whatever it is comfortable. If the sugar value fasting is less than 90 and postprandial is less than 120, we can go with the MNT itself. If it exceeds, then only we have to go for the pharmacotherapy. So usually gestational diabetes women usually have high post-breakfast plasma glucose compared to post-lunch and post-dinner. Normally, we monitor with glycemic profile, that is 7 times. So nowadays, it is very difficult for the patient to do 7 times. So the first week, you can do the blood sugar value before breakfast and after breakfast, and after 3 days before lunch and after lunch, and after 3 days before dinner and night dinner. This is the way we monitor the blood sugar value. So insulin is started within 1 to 2 weeks. If it is not controlled, we are going to start the insulin. As I told, fasting value is more than 190 and postprandial value is more than 120. Always we should have in mind 120 by 90 BP if it exceeds hypertensive disorder in pregnancy. Sugar value 120 by 90 if it exceeds hyperglycemia in pregnancy. So this 120 by 90 should be always in our mind. How are we going to calculate? But this is only the guideline, but it cannot be strictly followed. But to start with the earlier stages in the first trimester, we can calculate 0.7 units per weight in kg. So it has to be 0.7 units, 50 kg means 0.7 units into 50 kg, like that. In the second trimester, 0.8 units per kg, and third trimester, 0.9 units per kg, and 38 weeks and later, 1 units per kg. This is the way we can calculate the total dose, but depending on the sugar value only, it will vary. But this is for the basic guidelines. So first trimester 0.7, second 0.8, third 0.9, during delivery it is 1 unit. So insulin is the traditional first choice drug for blood sugar control during pregnancy. This is the only, as I told, this is the golden treatment because it is mostly effective. So, and it does not cross the placenta also. Next, how are we going to counsel the patient? The patient always will ask in the pregnancy whether we have to go only insulin, whether we can go for oral hyperglycemic drugs. But insulin is the gold standard. How are we going to give the insulin? Initial dose, we are going to give the regular and the intermediate acting insulin is given. NPH insulin should be given, and it has to be, there is no mathematical formula, 1 + 1 is equal to 2. We have to adjust the insulin value depending on the sugar value only. So that short acting and intermediate acting insulin is combined and to be given in the morning or afternoon, in the evening. So depends on the sugar value, it has to be taken. So how are we calculating the total dose? 2/3 of the total dose is given in the morning and 1/3 is given in the evening. That is with the regular insulin and the intermediate acting insulin. Even in the morning, the regular insulin and the intermediate acting insulin, how it is given, 1/3 dose of regular and 2/3 of the intermediate is given in the morning, and in the evening almost in the equal ratio, 50:50, 1:1. So total dose of insulin is 2/3 is given in the morning and 1/3 in the evening. The morning dose, regular and intermediate acting insulin is 2:1. In the evening it can be 1:1. So this is the way we are going to calculate the insulin for a patient. So if the patient continues to have the fasting hyperglycemia, the intermediate acting insulin given at the bedtime can be increased, or the regular insulin can be given before the dinner. So this is the way we are going to calculate. See, morning insulin, post-breakfast, pre-dinner insulin, post-dinner, and morning fasting, like that. If the morning fasting sugar value is increased, means night intermediate can be increased, or a small short-acting insulin in the morning can be increased. Depending on the effective and the duration of the act of the short acting and the intermediate acting, the dose can be increased depending on the sugar value. This is the simple picture which shows which is has to be increased, breakfast, dinner and everything, NPH and LNT, regular and intermediate, how we are going to increase. So normally the mean blood glucose value should be 105 milligram. Fasting is 90, postprandial 120. If you take it, random is not at all advised. But if the mean plasma value glucose is taken, it should be 105 milligram. So this is the way we are monitoring the blood glucose. So regular and intermediate acting insulin, 2/3 and 1/3, 2:1 and 1:1. Depending on the fasting and postprandial value, the sugar value has to be adjusted. So what are all the other types of insulin available is regular, intermediate, Lispro, this is a long-acting insulin, glargine and Detamar, these are all the analogs. The time of the peak effect, long-acting is 45 to 75 minutes and regular is 2 to 4 hours. NPH is 6 to 10 hours. Duration of action is, Lispro is 2 to 4 hours. Depending on this only, we calculate it as short-acting, intermediate acting and long-acting. So preferably, previously, we don't give the long-acting insulin during pregnancy. But nowadays, even the long-acting insulin and analogs are given during the pregnancy also. See, this is the insulin Lispro, is an analog insulin. This Lispro, because now I have never used this insulin, Lispro, the analog insulin, but Anjalakshmi madam is using this. So if any doubts, you can also be in a position to answer. Lispro is made by genetically modifying the structure of human insulin. So it can be absorbed more quickly and last for a shorter length of time than the regular insulin. It can be absorbed quickly and the length of time of acting will be short. And it can be administered 15 minutes before taking food and during food also, or with a meal. This is safer, since because of the shorter duration effect than the regular insulin. This means what it means, the Lispro better mimics how insulin is naturally released in response to food in people without diabetes. So it is like a normal insulin secreted in our body. So side effects are very less compared to the regular insulin. So the insulin Lispro, the analog insulin, is all nowadays used. So what are all the advantages with the insulin? See, it does not cross the placenta and pharmacokinetics not altered. Pharmacodynamics is not altered. Insulin Lispro is safe. And what is the disadvantage? Several daily injection is needed, and handling the refrigeration is very, very important. Immunogenic insulin antibody complexes crosses the placenta. The cost is also high. So advantage is it is safe, and disadvantage, if you take, it is the cost only. So the insulin is the gold treatment for controlling the sugar during the pregnancy. Why not oral hypoglycemic agents? If the patient is not willing to take oral hypoglycemic agents, what has to be done? Why we are not informing about the oral hypoglycemic agent? Because of the potential teratogenicity. What the oral hypoglycemic agent? Transplacental transfer. It crosses the placenta, and fetal beta cell stimulation, fetal hyperinsulinemia, fetal macrosomia, prolonged neonatal hypoglycemia. So what we tell, if the once the baby is delivered, if the sugar value is less than 30, hypoglycemia, so that can also, prolonged neonatal hypoglycemia can also be happen. But with the careful monitoring, nowadays oral hypoglycemic agents is also approved. So advantages: improved compliance and better glycemic control. What are all the oral hypoglycemic agents now we are using? Preferably, all of us know metformin. When the patient is in the PCOS, that is polycystic ovarian disease, it is usually a cycle. If the adolescent obesity is not controlled, she will go for obesity, PCOS. Obesity, 90% is the reason for PCOS. Once she gets married and become pregnant, she will go for GDM. Once the sugar value is not controlled, she will deliver the macrosomia. This macrosomia girl baby again go for PCOS. So this is a cycle. So always control the obesity during the adolescent itself. If the patient is taking PCOS during that adolescent period metformin, and she becomes pregnant with the metformin, it can be continued also. I will tell some studies after that. What are all the other drugs which can be used? Is glyburide. So current guidelines accept the use favoring metformin. Glyburide is associated with higher birth weight and more neonatal hypoglycemia. So most of the time it is not used. Metformin achieves satisfactory perinatal outcome compared to the other drugs. So long-term information about the glyburide is not known. So these are all the studies which tells that metformin can be considered as a non-teratogenic and reduces the risk of abortion by lowering the PA11. And women with PCOS treated with metformin throughout pregnancy have a much lower rate of miscarriage and compared to the person without metformin. These are all the meta-analysis which tells that metformin can be used with during pregnancy. So this is what are all the relative indications and the contraindications. When we can go for, as I told, if the patient is not willing to have the injections, it should be given 1 prick, 2 prick, 3 prick. In that cases, GDM not responsive to medical nutrition therapy and patient's refusal of insulin, you can go with this monotherapy of the metformin. So if the sugar value is high and if it is not controlled to the added value, you can go with the insulin therapy. The high insulin dose requirements can also be reduced with metformin. So these are all the contraindications, which is not so essential: medical status, metabolic, and obstetric status. So metformin is a category B drug and has many advantages It is an insulin sensitizer, prevents hepatic glucose production, prevents absorption of glucose from the gut, and has beneficial effects on the lipid metabolism. So metformin can also be tried during the, there are studies which tells that they are using only metformin rather than the insulin. Anjalakshi madam has also had one study telling about the use of metformin and also of the glibenclamide. Glibenclamide I have never used, but there is one study which tells that recent reports have good fetal outcome with the GDM with the glibenclamide. Treatment with insulin and glibenclamide resulted in similar perinatal outcomes. This is the 2007 study by our own Dr. Anjalakshi madam. Then comes the acrobose. I thought this acrobose cannot be used, but still there are studies. Again, I have one study from Anjalakshi madam and other studies also, who mentions that acrobose can also be used with during the pregnancy. It is locally acting, no systemic effects. It is a starch blocker and good postprandial control. Postprandial control is very good with acrobose as per studies. The side effect is mainly intestinal discomfort in the mother and no ill effects to the fetus and the baby. The dose is almost 25 to 50 milligram TDS. Again, I have never used acrobose. But as per studies, it can be used during the pregnancy and the dose is 25 to 50. This is one comparative study, comparison of the feto-maternal outcomes in patients with GDM treated with insulin versus acarbose. Again, in this study, they have come to the conclusions there is no difference with the perinatal outcome with the insulin and the acarbose. So there are again seems to be a promising option for the treatment of the GDM, and the madam studies, acarbose was found to be a safer and efficacious drug during pregnancy. Madam has been a guide in 2007 for one of the PG who were using this acarbose during the GDM patients. And the results is also the perinatal outcome is same as that of the insulin in 2007 itself. So this is the way we are going to treat. Only the pharmacotherapy I have dealt. So if the patient, the golden treatment is mainly insulin, regular and intermediate acting insulin, 2/3 and 1/3, 2:1 and 1:1. If needed, long acting insulin can also be used, and analogs are also nowadays used. As per the studies, metformin I have tried, and I have not tried the glibenclamide and acarbose. As per studies, this can also be used during the gestational diabetes mellitus during pregnancy, and there is no side effect. So monitoring the glycemic control is our aim. Success of treatment for women with GDM depends on the glycemic control. Monitoring is very, very essential. So after diagnosis, MNT for 2 weeks. After that, if the fasting is more than 90 and postprandial is more than 120, switch over to insulin, and you can try the oral glycemic drugs as per your choice. Once target blood glucose is achieved up to 28 weeks, fasting and PBG should be done. It is not in a once in a month. It has to be done once in 2 weeks after 28 weeks. And if needed, more frequently. If the insulin value is high, they are getting 20 units, 20 units, 20 units 3 times a day. In that cases, it doesn't mean that we have to monitor only in 2 weeks. We can monitor alternate days also. So depending on the sugar value, depending on the sugar value and insulin, the frequency has to be increased. In high risk pregnancy, more frequent monitoring with blood glucose, which only if it is a very, very high risk with a high dose of insulin means frequent monitoring of the blood sugar is important. Continuous monitoring dose is also available. They are more effective. What is the role of HbA1c, glycosylated hemoglobin? Normally, this will be useful in pre-GDM. That is, diabetic patient becoming pregnant pre-GDM and pregnant patient becoming diabetic is GDM. But if when the UPT test is positive and HbA1c is high, they come under the pre-GDM. So if the glucose intolerance is detected early, will be helpful to differentiate pre-GDM and GDM. In the first visit, if the HbA1c is more than 7 or 6, we consider her as pre-GDM and it is not GDM because she was not diagnosed diabetes during pregnancy. So HbA1c is useful in monitoring glucose control during it is before pregnancy in a case of pre-GDM. Pre-GDM patients needs pre-conception counseling and HbA1c is important, and then only they have to become pregnant. The estimation of fructosamine during pregnancy, we are not doing nowadays. So during pregnancy, the BP monitoring, fundus examination at that every trimester, is also important. So the sugar, insulin is the golden treatment, and sugar value has to be monitored. Always remember 120/90, fasting 90 and postprandial 120. Thank you. Once again, I thank the organizers for the wonderful opportunity. Thank you.
Thank you, madam. Excellent presentation.
Thank you, Radha.
It made us feel like PGs again.
Madam, thank you, madam. Shall I have few words?
Yes, Dr. Doris.
Thank you, madam. That's such a nice presentation. I am really a fan of you. The reason being your charm, your vibrant nature, and your social responsibility. And this topic was also a really very good, concise presentation of you. Thank you very much. And we obstetricians are shouldered with a social responsibility towards GDM, because after it has been started as a universal screening, we feel more and more it is a social responsibility burden on us to educate in the sense and also the management, obstetric management, as well as the diabetic management as a whole. And as you told, insulin is the gold standard, and still metformin is being right and left used by us, and it is giving good results also. And still many of us are reluctant to use glibenclamide and acarbose, and the study by Anjalakshmi madam is really can encourage many of us to use this. And one question, ma'am, HbA1c level at the initial first trimester, I mean at the booking time, what will be the cutoff for you? How will you counsel the patient if it is more than 6? And is there any cutoff for MTP?
No, we have only, if it is more than 6 means we consider her as pre-GDM, because she was not diagnosed as diabetes earlier. Even if the HbA1c value is 14, we can tell that with the 14%, you will have the anomalous. What is the congenital anomalous is possible. So we have to tell her, depending on the HbA1c, we have the congenital anomalies. If it is 10 means 14% like that, depending on the HbA1c, as it increases, the percentage of congenital anomaly will also increase. So we have to tell the patient that there is a possibility of congenital anomalies. It is only the patient's decision to take whether it can be continued or whether it can be terminated. So we have to tell 14% also, remaining 86% will be normal. If there is a 14% of congenital anomaly, means 86% will be normal. She may be a IVF and she may be a precious baby. So now we have a lot of pre-genetical analysis, fluid analysis. There are a lot of methods to identify the congenital problem for the baby. So depending on the HbA1c, I will never counsel the patient for termination.
Can I have a word?
Yes, madam.
Doris, the normal value of hemoglobin A1c during pregnancy is 4.5 to 5.5. There are not much of studies. Only one Indian study is there where it is a 4.5 to 5.5. So in a pre-pregnancy counseling, we should try to get the hemoglobin A1c at least 5.5 to 6. So anything more than that will be harmful to the fetus. Okay.
Okay, ma'am. Okay. Thank you. Thank you, ma'am.
And no, there is a question in the chat box whether Oclibose can be used. See, for using acarbose itself, people are hesitant because there was no studies regarding acarbose, very few studies. And my study has been quoted in even in the international analysis and all. Okay, so for acarbose itself, we are very reluctant. You can use Oclibose. The action, it is a next generation of acarbose and acts only at the intestinal stomach level. So it is not being absorbed. So you need not worry about the side effects of the OHA. You can use that.
Okay. Thank you.
People who are taking already Oclibose, that is a non-diabetic, they can continue. As they can continue the metformin, they can continue Oclibose.
Thank you, ma'am. Thank you.
Right.
Dr. Anjalakshmi madam is encyclopedia of diabetes in pregnancy. The GCT test was the PhD of madam. That GCT test came because of the PhD. Madam, can you tell the topic of your PhD, madam?
Doris, I presented the PhD after I left Thoothukudi, I think.
Oh, but it is being continuously used worldwide because very
Worldwide.
useful to screen, isn't it, ma'am?
Thank you,
Still now.
madam.
Thankful. Thank you, ma'am. Thankful to all.
Thank you very much, madam. The really very elaborate lecture. And of course, we do have Dr. Anjalakshi as the expert in the panelists. And with that, I would like Rashmi to take us to the next session, please.
Slide change, please.
Sureka, if you do any mistake with the GDM, Anjalakshi madam cannot sit quiet. Definitely.
Madam, that's why what I'm very much conscious of that, and that's why I decided the panel is with, like, for me would be just a traffic inspector. Like, I'll just pose the questions. I have the panelists who will answer, and then I'll all direct all the answers of the questions to Dr.
Anjalakshi madam.
Yes.
Yeah. Yes, Sureka. Thank you.
So Sambat, no, she is adding.
No, we are sure, madam, and we are really eager to listen to all your comments and expertise in this topic. We chose the topic for that itself.
Okay.
So the panel for today is hyperglycemia and pregnancy, and we are going to have a case-based panel discussion here. Rashmi, can you just go ahead with the introduction of our panelists?
The moderator of the panel discussion is Dr. Surekha Taide. She is the president of ISOPAR Vidarbha and the Savangi Obstetrics and Gynec Society. She's the unity in charge and professor at J.
You can let it be, I think. Rashmi.
I would like to introduce the panelists to the house. Dr. Geeta, she is the past secretary, OG SSI. Dr. Mithun Mahatme, the secretary, Panji OBGY Society. Dr. Deep, please change the slides, please. Dr. Geeta is head of the department. Previous slide, please. Dr. Geeta is head of the Department of Obstetrics and Gynecology, Dindigud Medical College and Hospital, Dindigud. Thank you. Next, please. Dr. Mithun Mukul Sinai Mahatme is consultant obstetrician, urogynecologist, endoscopic surgeon, and infertility specialist at Mahatme Nursing Home, Valshi, Bicholim, Goa. Welcome, sir. Next, please. Dr. Vanita Rukmini, madam. Madam is from Madras Medical College. She is senior assistant professor, Theni Medical College, consultant obstetrician and gynecologist at Theni and secretary of Theni Obstetrics and Gynecological Society. Welcome, madam. Next, please. Dr. Deepa Mukundan, a very dear friend of ours. She's a consultant obstetrician, gynecologist, and endoscopic surgeon. And she is past secretary at Trichy OBGY Society. Welcome, Dr. Deepa. Dr. Archana Ambujan, madam is director and consultant at OGCN and fertility specialist, Omega Fertility Center, Sundaram, Arunraj Hospital, Tuticorin. She's a gold medalist and has been awarded with the best outgoing student in MS award. Welcome, madam. Dr. Emmanuel Gracious, he is a secretary at Margao, OBGY Society. Welcome, sir. He's a program director at Gracious Hospital and consultant at Gracious Clinics. Dr. Aarti Dargal, madam is with special areas of interest in infertility and high-risk pregnancy and recurrent pregnancy loss. She's a laparoscopic surgeon. She's a member of IMA, member of Safe Motherhood Committee of TNFOG. She has taken parts in many academic activities, and at present she's the secretary of Irudnagar West Obstetrics Society. We welcome you, ma'am. And the expert for this panel is none other than respected Dr. Anjalakshi Chandrasekhar, madam. Welcome, ma'am. I would like to request Dr. Surekha Taide to kindly go ahead with her panel discussion.
Hello. So thank you very much, Dr. Rashmi. And as I have told initially, this panel hello. Okay.
Now you are audible, but I think the connection is a little, irregular connection, unstable connection.
Now it is okay?
Yeah, it's okay.
Yes.
Slideshow, you have to do.
Yes, ma'am, you can be
Somehow
heard.
I have suddenly I had lost connection and I'm back now. Okay.
We can hear
So
you crystal
anyways,
clear, ma'am.
yeah. Okay. Okay. Thank you very much. And I need to go on the right. So is it fine now, Rashmi?
Yes, it's absolutely
Yes,
fine.
ma'am.
Full screen.
Previously told also, this is a panel which I have devised as a case base, and what we would like to go through is the panel and the cases. In we would like the panelists to be brief and with the take-home messages, and of course, I would like Dr. Anjalakshi to give the expert opinion after each case and after each discussion. So these are the panelists who have been introduced to the house, and welcome panelists. Yes, rightly, Dr. Hema Divakar also has given the message. This take the first step, that is the Pehla Kadam, and that is the universal screening. Even today, only 28% of our pregnant women are being screened, and that's why what we have to really work is the universal screening. That means we have to screen all pregnant women, testing with 75 grams of glucose, and that is the single most important step for all of us, which we should take as physicians. And of course, by this, let us all do this for all our patients, and let us make the difference. So let us go to the first case. First case is this is a case of Dr. Geeta here.
Yeah,
She's a
ma'am. Good
known,
evening, ma'am.
good evening, Dr. Geeta. She's a known PCOS with impaired glucose tolerance, and she was on metformin 500 milligram once daily. She married recently, and she's now come to you in early pregnancy. Now, question is, what tests and advice in the first visit for this patient? Should she stop metformin? What about screening? Is there a need to do a fasting or postprandial blood sugar? What about HbA1c? Do you want to give the challenge test to her? What do you say, Dr. Geeta?
We have to do fasting blood sugar and postprandial blood sugar. Along with that, the HbA1c should be done to see her previous 3 months sugar values. I don't think 75 grams glucose challenge test needed for this particular patient. Metformin was given for PCOS with impaired glucose tolerance. We can see check the blood sugar values. If it is normal, after that we can decide whether metformin can be continued or not. There are two schools of thought. One is NICE guidelines say that we can continue metformin till 12 weeks because the miscarriage rates are less, as the previous speaker told. And another school of thought is the government of India says that metformin can be given more than 20 weeks. And then she needs the nuchal translucency.
Somebody's phone is ringing, I think.
Nuchal translucency test, and we have to tell about the visits to her. In this visit, every month she has to come and check for blood sugar levels, and every 2 weeks, 24 to 28 weeks, and after 28 weeks, every week she has to come.
Yes, Geeta, we'll go to the monitoring later, but question is whether to stop the metformin or whether what to do about it. Dr. Anjalakshi, your expert comments, please.
Yes. So this patient, she's a PCOS patient with impaired glucose tolerance, and she has become pregnant. Already she is on metformin. Okay. So you are, as Geeta said, you do the fasting postprandial blood sugar and also hemoglobin A1c, and continue the metformin, and you can increase the dose of metformin if the fasting and PP blood sugars are more. Already she is IGT. Now with the pregnancy insulin resistance, her requirement of metformin may increase. So you can increase the metformin up to the dosage of 2 grams per day, 2000 milligram. Okay, and beyond that, if the blood sugars, as Samrat Kumari was telling, the target values, fasting should be less than 90 and postprandial should be less than 120. That is there throughout the pregnancy, the same target goals. So if it is more than that, then you can add insulin. Okay,
Right,
so
ma'am.
there is no
So the
need
take-home
to
message
stop
is
metformin. No
yes,
need to
no
stop.
need to stop metformin,
Yes.
no need to do the challenge test because already she is having impaired glucose tolerance. The pregnancy is going to increase the glucose intolerance in this patient, and so she may need an increase in dose. So what we need to do is the blood sugar levels for this patient, and then we need to find out whether a increase in the dose is needed or whether she has to shift it to insulin if the that may be one of the thoughts which we can have for this patient. Okay.
By giving glucose, you will be producing a glucose toxicity and effect of the growing the fetus. Okay, so you should
Definitely.
not give frank glucose.
Not to give the challenge to this patient.
Yes.
Right, ma'am. So now this is for Dr. Mithun here.
Excuse
now
me,
this
madam,
patient-
Dr. Surekha, ma'am. I'm getting a call from hospital that health secretary's visit now urgently. I have to leave.
Yeah, Dr. Geeta. No worries. Please, ma'am. Thank you, Dr. Geeta. And we have been in discussion so much that I'm really sorry that you have to leave. Anyways, so this is for Dr. Mithun. Do we need to ask for an early ultrasound for this patient? What do you think? Does the early scan will predict the uterine artery Doppler, help to prevent and predict PIH? What do you say? What are other biomarkers? What do you think in this patient?
Now, since this is a patient who's already having PCOS, I would prefer to start her on prophylactic aspirin because anyway, it is known that those patients who are having, impaired glucose tolerance also, they have a higher incidence of PIH. So aspirin, as we know, is completely safe in a dosage of around 60 to 75 milligrams. So I would prefer to start prophylactic aspirin. That's the first thing. Secondly, as a routine, we do uterine artery Dopplers for all our patients because now it is easily possible to do it with the new machines. So I wouldn't shy away from doing a uterine artery Doppler. It also gives me a reference point to compare at around 20 weeks whether I would expect a PIH happening and at what severe degree it would happen. Predict and prevent. So most of the patients with GDM or impaired glucose tolerance for that matter have an incidence of PIH which is mentioned, which is higher than that of a normal population. So it would be better to either think of certain ways to either prevent it or maybe catch it up a little earlier and recognize certain patients who could be more prone to that.
Yes, Dr. Emmanuel, you do want to say something over here?
I am absolutely within the same school of thought of starting aspirin, aspirin 75. I completely agree with that. The rates of PIH and GDM going hand in hand are significant. In fact, it is quite significant that empirically we will start. And I completely agree with that.
Aspirin is
what about these biomarkers you would like to do or the clinical makeup of the patient itself will let us know that yes, these are the risk factors and yes, we do need to start.
I personally don't do any biomarkers. I feel that a lot of us can manage such patients clinically. See, what is the objective of the first trimester screening for diabetes? We need to separate those patients who are overt and those who are more prone to develop gestational diabetes. Yes. That is the basic thing because those patients who are overt, they need to be managed in a different manner, and those basically which are prone or having impaired glucose tolerance or gestational diabetes can be managed in a different manner. So
what do you say, Dr. Anjalakshmi? Any other things you want to add?
Actually, this patient, when you put into the gestosis score, she'll have a high score. You have to start her on prophylactic aspirin, and the dosage now accepted is 150 milligram, not 75 milligram. Okay, it is also very safe. So the 150 milligram we have to start. And the uterine artery, at 11 weeks, you can do a transvaginal uterine artery Doppler, and you can predict whether she can develop a PIH later. And also biomarkers, actually when we do the NT scan, we combine with the biochemical screening also. So in that we have a PAP-A and the HCG and also this placental growth factor. These can help to predict the possibility of a PIH in that patient. Okay.
Definitely.
And,
so what are the take-home messages here is that yes, we should do the gestosis score for all our patients. So it's a very simple clinical score. The gestosis score will tell us, and yes, the aspirin 150 milligram and uterine artery Doppler as a baseline is very important, so that we can have a follow-up later on. And the screen not only for PI but also for chromosomal anomalies, because these patients are again prone for anomalous babies. So that is what I think. The first trimester is very, very important as far as gestational diabetes patient is concerned. And like we said, the inverted pyramid of antenatal screening, they need to be seen more frequently in the first trimester as compared to the others. So thank you very much for all those take-home messages, very nicely put in, Dr. Mithun. So here is this patient, Dr. Rukmini, for you. What are the chances for anomalies which you said? Which one is the common? How do you follow up these patients? And do you think the ultrasound is having any limitations in picking up these anomalies? Dr. Valita.
Yes, thank you, ma'am. And congenital anomalies are very common in diabetic mothers, ma'am. The two hyperglycemic states in the period of organogenesis is the reason behind the congenital anomalies. And it is roughly about 6 to 10% in diabetic mothers. When compared to normal pregnancy, it is around 3%. And the best predictor here is to find out the risk of occurrence of anomalies being hemoglobin A1C, which if more than 10, there is approximately about 22 to 25% of congenital anomalies. And the commonest malformations being cardiac anomalies, followed by open neural tube defects, renal and gestation, GIT anomalies also follow. And obesity and positioning of the babies during NT scan may have some limitations in finding out some anomalies.
Right. So definitely, I would say that the glycemic status of the patient will also predict what amount of anomalies this patient will have. And this hyperglycemia itself, I think, is the mutagen which will provoke all these anomalies in these patients. And as rightly said, we are having, equal number of, we are having the highest rate of what do we say, in these high proportion of CNS, CVS and renal anomalies in these patients. What we are seeing that if it's an anencephaly, then 100% detection rate. But if it's an other anomalies, even a spina bifida occulta, then there may be some limitations in detecting the anomalies in these patients. So obesity again adds to the problem. So we cannot say that we will be able to pick up all these anomalies, and that's why we need to have an expert here who would be doing the ultrasound for us. So again, it's very important that we do have an early screening in these patients. Even the first trimester, we are able to pick up some markers and some anomalies in the first trimester itself, and again repeat the scan in the second trimester. Anjalakshmi ma'am, anything else to add here?
And the next thing is, in the limitations, of course, associated obesity can give rise to problems. So you should have an expert sonologist. And remember the gastrointestinal anomalies, it cannot be picked up in the first and the second trimester. Sometimes early third trimester only we'll be able to see. So we have to, in counseling, we have to counsel the patient and let them and prepare the patient to accept and make a decision. Suppose we detect it later also. So we have to tell them that some of the anomalies we cannot detect at the earlier stage where we can do a safe abortion. Okay, so the counseling is very, very important as far as the malformation is concerned, especially when the hemoglobin A1C is raised. When it is more than 10, it is about 25 to 30%. But other 70% will be normal. So we cannot advise termination straight away in the beginning. But we have to counsel them the possibility of anomalies and also possibility of detecting only in the early third trimester, and they have to take an appropriate decision.
Right, ma'am. So
I'd like to add that, more than anything else, it's the medico-legal aspect of everything. Once the HbA1c is elevated, I think it's very important that we document that we have counseled the patient, take it down, because there are a lot of times that the anomalies could be missed and then she could hold that against us. So I think medico-legally also an elevated HbA1c is a big red flag for us, even especially in the current medico-legal environment.
That's
definitely
counseling and prepare them.
Yes,
Yes,
absolutely,
and
madam.
some of the
Absolutely.
anomalies keep on evolving also, just like you said that it
Exactly.
could be
Yes.
detected in the third trimester. So
Yes.
what then? So we have to document really that we have counseled, and we do tell them that if the glycemic status is not in control, then probably we will be able to we'll be seeing more challenges in this patient, and the couple has to agree to it, and they have been counseled about it. So with that, now again, the next question quickly following that is, now your HbA1c is 9.8. You know that the anomaly is going to be high. You want to terminate this pregnancy, Dr. Deepa?
First of all, good evening to everyone. Dr. Surekha, thanks so much for inviting me for this wonderful panel, especially with stalwarts like Anjalakshmi madam. Madam is the real authority in diabetes. So I'm just enjoying this panel. I think Dr. Sampath did a wonderful talk. She answered most of my questions. I think HbA1c of more than 8 is supposed to be associated with a lot of adverse outcomes for both the mother as well as the baby. It's not a good diagnostic test, but it has a very good prognostic value, especially in the first trimester. So if the HbA1c in this patient is going to be 9.8 and she is a PCOS patient with already impaired glucose tolerance, she might have a difficulty in conceiving. So I would just offer her the options. I'm not going to decide for her. I will just give her the options that here there is a small chance that she might be at a higher risk for miscarriages as well as fetal birth anomalies. And it is for her to decide whether she has to terminate or not. And I will just give the figures. If the HbA1c is above 10, there is a 10% risk of anomalies. And if it is above 12, there is a 20%. So the more the HbA1c, the greater the risk. So that's where the concept of preconceptional counseling comes. I would like to, preferably I would have seen this patient well ahead before she planned her pregnancy.
Yes, but
so
what
that,
you would like to put in that you would like to give her the options, you tell her the figures, the statistics, and let them decide. Maybe this is she's been having fertility issues and she has conceived, out of. So
very
now
difficult to advise
yes.
a patient with infertility for termination. It's
right.
almost
So
impossible.
Very difficult, as rightly put, Dr. Manuel. But definitely we have to tell them that these may be the problems, and otherwise later on we ourselves will be in soup if we don't advise, that these are the problems which can be associated with. Do you want to add anything, Dr. Anjalakshmi? We go ahead.
No, actually, no. With the raised hemoglobin A1c, you counsel the patient with the statistics.
Right, ma'am. And then we can give them the option whether they want to terminate or not is their choice.
Yes.
We give them all the options. We tell them what are the possibilities, what are the challenges in their own case. So this is this patient. What do you think are the missed opportunities? What about the pre-pregnancy counseling in this patient, Dr. Archana?
Good evening, ma'am. Thank you, Dr. Surekha, for inviting me today. And we hardly get a chance in a periphery like ours. We hardly get a chance to meet the patient in the pre-pregnancy state. Most of them come to us after they're pregnant, and it's quite difficult. But if we do get a chance to, I would first of all like to check her BMI. That's one important thing. And particularly when she's a PCOS, most of the PCOS, they seem to have a higher BMI. I would like to advise her on starting her diet and exercise even before her pregnancy. Of course, start folic acid for her, which is very important in the pre-pregnancy state. And also check her sugars. Probably when she comes to me in the pre-pregnancy state, it'll be easier to check her HbA1c and control sugars with initially diet and exercise, and if she requires any drugs, and then plan for pregnancy once her sugars are brought under control, so that we can avoid problems of these congenital anomalies, which she will encounter if she goes into pregnancy with the hyperglycemia.
Right. So this was a case of PCOS who was married recently, and I think without any intention she got pregnant. So we do have to advise these patients especially if the BMI is high, if there's obesity. First, we need to ask them for the control of the weight control. I think is important. And contraception till, I think if this patient is already a known diabetic, then till the control is there, glucose control is such that we can advise her for her conception. So there has to be a good control, and then only the patient should go ahead with the pregnancy. So that is, I think, what we need to create an awareness. Most of the time, in 40-50% of the cases, the pregnancies are unintended pregnancies, and that is where the problem actually is there. So again, the folic acid, which is much required in these patients, not only in this, but all women, we need to have this pre-pregnancy counseling. Anything to add, Dr. Anjala?
See, this patient, as you said, recently she was seen and got married immediately. So that time we should have made use of and told her the importance of pre-pregnancy counseling and maintaining the blood sugar in the euglycemic state, and also controlling the blood sugar.
Yes, yes.
It is, we have to.
So again, Dr. Anjilakshi, we have another case, and this is for Dr. Emmanuel. She's a 22-year-old, first delivery at 3.9 kg baby. 11 years later, she conceived, and now BMI is 30. She came to you at 12 weeks of gestation. You did the single step test, and 248 is our report. HbA1c is 8.8. Now she has not been assessed pre-pregnancy. What do you think about the missed opportunities? What would be your tips for practice for all the listeners here, viewers, Dr. Emmanuel?
So now, since she's 12 weeks and at 256, it's quite obvious that she's over diabetes. She's, or we would say, pre-GDM. So for this case, I would definitely try to advise her an admission. So at least we could get her glycemic profile. I understand that sometimes doing 7 readings at home is inaccurate. The patient is not going to be okay with tricking herself. So I try to get these patients, at least I'll use the thing that, that's because she's conceived after such a long time. So I'll, first of all, in my mind, she'll be a precious pregnancy. I'll admit her, do a glycemic profile, and mostly looking at her sugars at this state, mostly she will need insulin management.
Dr. Emmanuel, what I wanted to focus on was that previous history of 3.9 kgs, and BMI 30. Do you think that this patient could have been diabetes, prior to the pregnant status?
Yes,
itself?
absolutely. As I said,
during the 11 years, she should have been screened. This is an undiagnosed case of this diabetes mellitus, I think, which have been missed. And then in high prevalence countries like India, the screening should have been part and parcel of the preconceptional counseling care itself. Though there are limitations, 40% I said the pregnancies are unintended, but still if we would have diagnosed it prior to the pregnancy, probably she has gone to 12 weeks and her glucose levels are 248. They're very high.
Absolutely. As Madam also said,
already been exposed to the hyperglycemia.
The damage is already done.
So that is where I think the opportunity have been missed. And that is what I'm talking of when you're talking of in our own practice, that these cases where the first baby is already 3.9 kg, here are the patients we have to advise on follow-up, maintaining their weight, their diet, and accordingly, if they want to embark on the next pregnancy, it should be a planned pregnancy. What do you say, Dr. Anjilakshi?
Yeah, this patient had a first baby of 3.9 kg, which is a macrosomic baby for our Indian standard, and 11 years of infertility. Suppose she would have gone for the infertility evaluation, a simple sugar test would have helped to detect this hyperglycemia before actually. And that is the first step where we have missed actually the hyperglycemia. And second, at 12 weeks only, they have done the blood sugar test. They have done the one single step. Okay, that is 248. So all damage has been done in the organogenesis period.
Right, ma'am. Right. And already the baby is having a high chance of having an anomaly.
Absolutely.
So that is where the missed opportunities in this patient.
And
so this is a case to
microangiopathies. because if there is anything, it can be treated. Otherwise, the pregnancy advancement will worsen the condition, like nephropathy and proliferative retinopathy. It will worsen the condition. So they have to be looked for.
Yes, ma'am. So this is the case too. Multigravida, she came late at booking at 30 weeks of gestation. Her last childbirth at 3 years was 3.5 kg. And again, when you did her sugars, it is 240, which is quite high. So now this is again a real problem when your patient is coming late in the pregnancy. What is Dr. Aarti for this patient? How are you going to manage? Do you want to show to the diabetologists? What do you want to put on insulin? What should be a monitoring and what should be our target sugars for this patient?
10 more minutes.
No, we're not able to hear you. You're on mute, Dr. Aarti.
Yeah.
Yeah, thank you.
Yeah. Good evening, everybody. Thank you, Dr. Surekha. We're enjoying the panel discussion very much, ma'am. Yeah. The patient has come very late, ma'am, and the blood sugar is 240. So now we have to decrease the sugar, to prevent the problems like macrosomia and other things, whatever we can do. So we have to do the fasting and postprandial sugar and HbA1c. By the glycosylated hemoglobin, we'll be able to know how was the control in the last month. And then we'll have to start insulin for her because if her fasting and postprandial sugars are high. So as Sampath Kumari madam had told, we'll have to keep them both 120 and 90. So if it's more than that, then we'll have to start her on insulin. And the first thing
already it is 240, Dr. Aarti, so I think she needs insulin.
Yeah.
And what about HbA1c? HbA1c actually will predict the glucose control in the prior 3 months. In this patient, we are already 240, so we do know that the control is not there. So in this patient, HbA1c probably has no role to play. Yes, you may need a diabetologist reference for her. You need to screen the organ damage in this patient, and insulin, of course, you need to start. Which insulin you would like to start, Dr. Aarti?
Insulin, we can have a mixture of regular insulin and NPH insulin, or you can also start with insulin Lispro. And basically, education of the patient is very important. If we educate the patient about diet and exercise, our half work is done. The patients, they want a healthy baby, and if the sugars are normal, then only they will get a healthy baby. Otherwise, there will be a lot of problems. So if we give home the message to the mother, our half work is done, that if the BMI, if it's more than 27, she has to have 25 kilocalories per kg. If it is a normal BMI, she can have up to 30 kilocalories per kg. And if the BMI is low, she can have up to 35 kilocalories per kg. In that, the carbohydrates can be up to 55%, the proteins will be 20%, and fat around about 25%. And the carbohydrates should be preferably complex carbohydrates, like it could be ragi or jawar, bajra, and the fruits and vegetables should be preferably with the cover. We should have complex carbohydrates and preferably no sugar, and proteins also should be dal also with cover, so that it will decrease the certain hyperglycemia. And they will have to check after a normal diet and insulin, the sugar should be checked 3 or 4 times a day. In the morning fasting, post lunch, post breakfast, and post dinner, and try to maintain as properly as possible, because increased sugar, it is going to lead to a lot of problems. If we explain them properly, mostly half of our work is done. And while getting ready for our discussion, I just went through a very nice quote in one book. I just want to read it for everyone. Pregnancy is considered as a tissue culture experiment, implicating that placenta and fetus, they develop in an incubation medium that is totally derived from maternal fuels consisting of glucose, amino acids, and lipids. An abnormal mixture of maternal nutrients may modify the phenotypic gene expression of the newly forming cells, leading to short-term and long-term effects on the offspring.
Thank you, Dr. Aarti. What I would like to stress upon is when we are advising diet this patient and when we tell them, okay, this much amount of protein, this much amount of carbohydrate, they're not going to understand, right? Especially I'm working in a rural area and you really have to tell them what exactly they have and what options. So we do send them to a dietitian. We give them a diet chart actually. And yes, in the breakfast, you can have these alternatives and how much to have and what portion of food they should have and how frequently the meal should be had. So what is advised is go to six frequent meals, small meals. And definitely, I think what we should do is create a chart for them with good options, homemade food, which will give us what you have rightly said, a combination of proteins, high proteins, and complex carbohydrates. So that is how I think we should go about with the diet. And yes, these are the insulins. This patient is going to need insulin. We have to remember the lispro aspartate. That's a quick acting insulin. So when we give you a regular insulin, it takes around 20 to 30 minutes to start its actions. So that is where again the counseling for this patient. Yes, you have to take the insulin 20 to 30 minutes prior to your meal, and then probably you can have your meal. So anything to add, Dr. Anjalakshi here?
Yes. This patient had a hyperglycemia in the third trimester. Could have been tested only in third trimester or tested previously in the first and second being normal. Now she has shown hyperglycemia. So the hyperglycemia in the third trimester will give rise to anthropometric changes in the baby. That is the macrosomic baby, and associated with that all other problems, and also the neonatal hypoglycemia, RDS, all those things she can get. Your strict control of blood sugar is very important. Since we have detected very late, insulin has to be started along with the diet and the exercise. Okay. Regarding the diet, the simple way you said you were working in a rural area. So now the artist group have released a plate, a GDM plate. That is an 8 inches plate where 50% of the plate should be with the vegetables, the fiber diet. Okay. And 25% should be the carbohydrate. That is a rice and the major meal. Other 25% will be protein like fish, mutton, all those things. Okay, so we can advise them about this diet. Okay, and regarding insulin, any insulin can be used. Actually, no, they well tolerate with the intermediate acting insulin, that is the NPH, which we can start early. And one clue I want to tell here is Dr. Sampat Kumari was telling the insulin requirement and different requirement in the 3 trimesters. That is the overall insulin requirement for the person. In the first trimester, 0.7 units per kg body weight. So if you multiply into 50, it is 35 units. We don't know how much of insulin we have in our body and how much we have to give. The other thing is the insulin sensitivity also differs in different individuals. So we have to start with small dose. I will give you a clue here. You can calculate as 0.1 unit per kg body weight. Any JDM patient, you can calculate the insulin like 0.1 unit per kg body weight. So start with 4 units twice daily, 6 units twice daily, like that. Okay, and slowly with the monitoring, once in 3 days. Here you have to have a close monitoring. Once in 3 days, you check the glycemic profile. By that we mean 7 times and 1 in the early morning. We can do that and adjust the dosage of insulin. That you can learn yourself. Actually, if you add, you have either you start with the intermediate acting insulin alone, or you can have a pre-mixture of this short acting and the intermediate acting, or even you can have a split and mixed dose. So any regime you can use, and you can adjust the dosage of the insulin, various insulin, according to the glycemia we find in the daily monitoring.
Right. So what we do actually is admit the patient. Yes, we admit the patient. Yes, and then we start the patient 444. In my practice, I do that.
Yes.
444 insulin, and after 48 hours, we'll repeat. We'll look at the control, and then accordingly, we titrate the dose.
Some people know they are afraid to start the insulin. For them only, they can calculate as 0.1 unit per kg. Suppose 60 kg lady means you can give 3 units in the morning, 3 units in the night. If you are going to combine the short acting and intermediate acting, there is 1/3, 2/3 combination. So like that, you can increase the dosage.
And I think there is no need to be afraid of the insulin. 444 insulin is hardly anything, I think.
Yes. Normally, the normal pregnant women, they have so much of insulin resistance, they can tolerate 30 units of insulin per day without any hyperglycemia, without developing hypoglycemia.
Right, ma'am.
Okay? A
So,
normal glycemic women can tolerate 30 units of insulin. So there is no fear to start insulin. Should not have any fear. Okay. And regarding the long-acting insulin, Detimer we can use in a non-diabetic if they have already started on the glargine insulin. Glargine is also a long-acting insulin, goes by the name Lantus. If they have already started and the glycemic control is good, you can continue.
You can continue. There is no need to be afraid. But initially, they used to tell us that long-acting insulin we should avoid. But if the patient is already diabetic, she's already on glargine and it's adequate control is there, then we can continue that glargine.
No need to change that. Okay.
Right. And no, we shouldn't be afraid of that hypoglycemia, even in these long-acting, because their body is used to that glargine. So we need to continue it. So that is the take-home message from this. So what about the fetal surveillance? Dr. Geeta is not there. Anybody would like to, what about the ultrasound? When should we do Doppler? Can we predict stillbirth? What about the fetal surveillance? Dr. Deepa, you want to take the question? Yes, Emmanuel.
Yeah. So, I think Dr. Deepa, she's there, no?
No, Geeta is not there. Emmanuel, you can take the question.
I think that in terms of fetal surveillance, it depends on how we are managing have the sugars been managed or not? Now, if the sugars have been managed well, then I think that we can restrict ourselves to just a scan every 4 weeks to rule out macrosomia, polyhydramnios, or the same. But if the sugars are not well controlled, the patient is not cooperating, she's not, not following her insulin management, I think seeing her every 2 weeks is important. So how many times we are calling her in and what we are doing is based on the fact that whether she's following our instructions or not. So
she's already having 240 blood sugar, this patient, and she came to us at 30 weeks. So definitely we would like to hospitalize her. And you need a frequent monitoring for her.
Frequent monitoring.
Yes. More frequent than 4 weeks, I think, in this case, so that we can detect if there is the macrosomia in this patient. And Doppler, of course, we would like to know
Doppler,
the Doppler.
But
sometimes it happens with Doppler. Yeah.
If you are looking for macrosomia, the maximum we can pick it up is in 2 weeks. We're not able to pick it up in a week. That's what I mean. So by keeping her admitted for fetal surveillance, you can keep her admitted to manage her sugars, but the fetal surveillance you cannot admit her till term.
No. So once there is a control, you can discharge and ask her to come for frequent follow-up. Maybe
at least that is what I feel. Yeah.
Yes. But what about the Dopplers? If there is a FGR and there is fetal hypoxemia, we are able to see the classic redistribution. But in this diabetic patient, what happens, because of the fluctuation in fetal blood pH, the Dopplers may not reflect actually the severely compromised fetus. There may be a normal Doppler, but there may still be a compromise. That is a problem in the diabetic patients, and that's why there is more chance of the sudden IUFDs which we see. Yes, Dr. Anjalakshmi, your expert comments.
We have to remember that the IUGR babies, they have a characteristic Doppler changes. Okay, when there is a vascular affection, the characteristic Doppler changes will be there. The same way, when there is anemia, we have a characteristic Doppler changes. Like that, for hyperglycemia, there is no characteristic changes in the Doppler. So by looking at the Doppler saying that it is normal does not mean that baby is normal. As Surekha was telling, the pH changes, the electrolyte imbalance that can occur at any time and can result in a sudden intrauterine death. So a normal Doppler cannot predict the well-being of the baby unless there is associated vasculopathy or causes for anemia is there. Okay.
And if there is an FGR, these diabetic patients are the babies are supposed to be macrosomic. And if it is the FGR, that means the vascular, the thrombin.
FGR can occur, Surekha.
Yes,
FGR
and
can
that
occur
means
in cases of
severe
non-diabetic having vasculopathy, and also in patients who are having PAH can have a vasculopathy. So
it means that the worsening of the condition is there, and a chronic condition is there, which is leading to FGR. Otherwise, these patients are supposed to have macrosomia. My dog is barking a lot.
Yeah.
Is it disturbing? Okay. So, how reliable is the fetal weight estimation by ultrasound, Dr. Mithun?
Yeah, so this fetal weight estimation by ultrasound basically can go wrong up to maybe 25%. So we cannot just go based on the estimated fetal weight gain that happens based on the ultrasound. See, whenever we would like to estimate the average weight of the baby, we would not only go by ultrasound, but it also is based on our clinical judgment. Secondly, whether the values of the ultrasound measurements are above 90th or 95th percentile. Clinical examination, measurements, all these basically gives us, should basically come to an idea as to what would be, whether the weight of the baby would be more than what we expect or it is basically average. So, but we have to keep in mind that despite our best efforts, that there is a margin of error, that it could go either ways. But going by the condition itself, that is a patient with gestational diabetes, we should always remember that despite even having a normal weight, we could land up in a situation that at the time of delivery, this patient could have, shoulder dystocia or anything. So whenever a patient is a normal patient, you land up with shoulder dystocia, we can say that it skipped our attention. But those patients with gestational diabetes, we should expect this thing to happen. So we should be more aware, we should be more careful, and not only go on the ultrasound parameters or any estimates that we normally do. But I think there are a few slight pointers, One is that when you do a routine examination, ultrasound exam, if the abdominal girth is bigger, let us say, so, you can suspect that, because that is more amount of fat in around the liver. So these patients are more likely to this. Secondly, the presentation is not the head is just not engaging. I mean, it is taking time. The weight of the baby appears slightly bigger than the average for that particular weight of the mother. So you have to keep in mind that you could always end up with a surprise.
What we have to look into is the clinical picture as a whole, I think.
As a whole,
the ultrasound is it's going to have a sensitivity only of 56%, and there's also always going to be a difference in weight of almost 15% and as high as 25%. So actual weight may be more and may not show up. And also there is an inter-observer as well as an intra-observer difference. When you do a variability is quite high as far as the weight, estimated fetal weight is concerned.
Actually, to this, I would, share a small thing, anecdote. When we were residents, we had very senior consultants who were our teachers. And, we had all these modern gadgets of ultrasound, new ultrasound machines were coming. So everybody started estimating fetal weight and things. But there were few of our senior consultants who just come and just examine the patient. They would just place their hand on the abdomen, palpate, and you would say, no, this patient is not for a vaginal delivery. You will end up with a problem. And inadvertently, if the patient is to come in labor at night, and by chance, if she had gone through a part of labor, we realized that this patient would not deliver. So this, this idea of holistically seeing the entire patient, considering the entire picture, and then taking a call, I think is more relevant also.
Yes, Dr. Anjali.
Also, in all of this, we missed maternal weight, no? Also.
Yeah.
See, actually, the macrosomia you can detect by doing when you are doing the anomaly scan, the abdominal circumference, if it is more than 75%, 75th percentile, then you can anticipate a macrosomia in this patient actually. And when it is beyond 90th percentile, then it is macrosomia. Okay, so you can actually adjust the dose of insulin according to the abdominal girth also.
Yes,
So
absolutely.
one thing. Another thing, as Mithun was telling, even a normal size baby, say about
Yes.
3 kg baby, a non-GDM baby will deliver normally, whereas a GDM baby can end up with a shoulder dystocia.
Correct.
Now, the new parameters, ultrasound parameters have come to increase the sensitivity of the, or to increase the accuracy of the fetal weight calculation, like cheek to cheek diameter.
Yes.
That indicates the fatness. You can
Yes.
see actually in the ultrasound, a diabetic baby, you can well appreciate the full cheeks. So the cheek to cheek diameter, the fat around the humerus, and also interventricular septum thickness. Based on that also, the weight of the baby can be calculated. That is, macrosomic baby can be identified. Not only the weight, the macrosomic baby can be identified. That is the
And then, madam, I think we should be in the habit of
fatness.
following the baby on the growth charts. You know,
Yes,
we should be having that habit also of looking at the growth chart and the percentile where the weight is falling, and
Yes.
accordingly
Yes,
taking
very
decisions.
important.
Right. It's important that we look at the growth charts of these babies. The abdominal circumference should also be charted out, and we should be able to, you know, find out which percentile they are falling and accordingly make our decisions. So thank you very much, Dr. Mithun, for that, Dr. Anjalakshmi. And what about steroids, Dr. Vanita? What do you think? Can we give steroids to this patient for lung maturity? What do you think?
Yes, ma'am. Steroids can be given because diabetic mothers will have delayed lung maturity because this hyperglycemia will causes decreased surfactant production, and so steroids can be given. And
when would you like to administer them? Would the insulin requirements differ? Would they require more insulin if you give steroids? What is your idea about that?
Both betamethasone and dexamethasone are equally efficacy with good effectiveness, but dexa is preferred by Government of India because it is widely available, and it has got little bit decreased chances of reducing the intraventricular hemorrhages to the baby, and it's low cost. And when you administer steroids, we like to admit the patient because the hyperglycemia state will be there even after 3 days of admission of steroids, and we have to monitor the blood glucose levels every 6th hourly. And so
yes, the insulin requirement is maybe increased when we are giving steroids in this patient, but definitely if needed, in case of these patients are coming to us in premature labor, then we really need to not routinely, but if they are coming to us in preterm labor, we are supposed to give. Then we need to give it, and then of course we need to admit this patient because we have to monitor the glucose level and accordingly adjust the insulin for this patient. Anything to add, Dr. Anjali?
Just add something. I don't think there is a role for routine administration of steroids.
No routine,
Yes.
only if the patient,
unless they come in preterm labor or they have they are at high risk for preterm labor, like polyhydramnios or effaced cervix or something. So
what do you think, Dr. Anjali? Polyhydramnios, we need to give steroid?
Pardon?
Polyhydramnios, do you give steroids? What we do in my practice, if patient is coming to us in preterm labor, then we give.
Preterm delivery. If you anticipate preterm delivery,
there is an effaced cervix, then
no, but I
there
think
is a role.
what Madam said is correct. Polyhydramnios sometimes come with effaced cervix. You see them in the morning with polyhydramnios, and the next day they come with effacement and leaking, and also I think polyhydramnios is a trigger for the physician to give steroids.
Actually,
that is
I think there is a yes, Dr. Anjalakshmi.
Yeah. See, the steroids, actually in GDM or in a non-diabetic, actually pulmonary lung maturity is being delayed. And because of that, even if they deliver at 38 weeks, the features of prematurity may be there. So wherever you anticipate a delivery before 39 completed weeks, you give a steroid. And we all know the steroid increases the blood sugar. It increases here more than 50% of the blood sugar level is increased. So she requires, even during that time, a strict control is important. So increase the dose of insulin. So you can say that insulin monitored treatment you have to give actually. So that is blood glucose you monitor and adjust the dose of insulin. That insulin increase requirement will be there for 3 to 4 days. After that, slowly you can come back to the pre-corticosteroid level of insulin. So
Yes,
it is a must, and monitoring the glucose is very important.
Okay, ma'am. So again, the take-home message is steroids, if required, should be given. Depending on your clinical, you do have your factors which would predict a preterm labor in this patient. So depending on our score, Peppernick score is there for this to predict the preterm, and then accordingly we can give the steroids. For that, we need to admit the patient and monitor the glucose level and adjust the insulin. And after the steroids are over, we can go to the pre-steroid level. So that is the take-home message as far as steroid is concerned. Any of the steroid can be given, either betamethasone or dexamethasone.
So in the pediatrician, they tell in the betamethasone, that particular salt which will help for the lung maturity is not available in India.
So betamethasone propionate, which is available, and it is not.
Okay.
Yes, Dr. Deepa.
Yes.
I think, so this is the third case, 39 years, IVF pregnancy, BMI 32, OGTT at first visit 160 at 12 weeks. And she was started on insulin. So, Dr. Deepa, she's not willing to take the insulin. Would you like to give oral hypoglycemics in this patient? And what is the evidence for this? And what is the reality, really? What is feasible in our country?
Actually, oral hypoglycemics, especially metformin, has been approved by many bodies for use in the first trimester. The teratogenicity is much less or not as alarming as the other drugs. And it is practically safe for patients. She's just got a blood sugar value of 160. So she will need a small dose, in fact. First of all, we'll have to put her on a diet and a proper exercise regime. And then if she's not willing to take insulin, will be the ideal drug of choice. But if she's not willing to take oral hypoglycemic agents like metformin is good enough in the first trimester and even up to 20 weeks. Although the government of India also says that after 20 weeks, metformin can be given. So actually it is a controversial thing. In patients with polycystic ovaries, in fact, metformin can be given because they reduce the risk of miscarriages by inhibiting plasminogen activator inhibitor and all those pro-inflammatory substances.
So only metformin, other oral hypoglycemics we need not give, we should stop. Only metformin is the one which can be given as an alternative to insulin, as an adjunct to insulin even. So if insulin requirement is too high, we can add metformin and you get a good glycemic controls. That's what the operational guidelines from Government of India also has come, and many bodies also, a lot of literature is available which supports the use of metformin. What do you say, Dr. Lanji Lakshmi? You think we can go
actually
that?
In our patients, Indian patients, they show very good results with metformin.
Right.
Okay. So this patient, but this particular patient, she's 39 years and conceived with ART. So I will counsel her sufficiently that the baby is very precious and we'll start her on insulin. If she's still
the counseling is the most thing. Exactly, I agree with you. Counseling is the most important aspect in this case.
Yes,
which
yes.
must
So
have come
even if
after so
she's-
many years. I will convince her, I will do whatever it is, but I will put her on insulin. There is no question that she doesn't want.
So I
Because
think,
it is
Dr.
first of all
Emmanuel,
two
I
things.
take that as a very good take-home message from your side that yes, the patient may
Because
refuse.
there are two
She's
things,
already
ma'am,
30
that I take
weeks.
from this case.
So she's already 30 weeks. So she just
No,
needs
not
to
that.
go.
Not 30
No,
weeks.
not the
She's
30 weeks. This was the
12
case which was
She's
12
12
weeks.
39 years ART pregnancy. Okay.
And
No
she's only
question.
12 weeks.
So she knows the importance of the baby.
And
so for baby's sake,
the
she
two
has
things.
to take insulin
Yes,
apart from
and-
her diet and the exercise. Okay.
And there are two important things here. Number one is she's precious, and number two, it is planned. There is no question of picking up surprise diabetes in IVF. This patient must have been with us for 2 to 3 months. She's taken hundreds of injections to get this pregnancy, one more addition to those 100, I don't think we'll see a problem.
Yes.
Because
So,
the poor girl must already be on
Dr.
low molecular
Emmanuel,
weight heparin.
I agree with that. I agree with that.
Yeah.
The discussion
It's
want to be on metformin also.
So yeah, so actually
she's on-
diabetics can have hyperemesis gravidarum also, and it's an ART pregnancy. I hope it's not a twin pregnancy, in which case the management of the glycemic control can be difficult with metformin. So that is the case where I will put her on insulin. Anyway, the
And
counseling
she's already
will
on
be
low
more
molecular weight
important.
heparin. So already one injection every day.
Dr. Emmanuel, I would like you to read this question also and take up it. I'll take care of my dog. Is it fine? You read the question and please answer it also.
I'm reading. My video is off because I'm driving. I'm in a car going to the hospital for a delivery. Challenges you expect.
Okay, so she's a 39-year-old.
Okay, so now IVF and GDM. Yeah.
What more challenges you're expecting?
You can read it to me, but I cannot see the phone actually.
Yeah. Preventive strategies for any more challenges.
So the most important thing, I think, she's 12 weeks with us, no?
Yeah, 12 weeks now. At the time of diagnosis, 12 weeks.
So she is going to, we will have to get her glycemic profile. So I will be admitting this patient to get her good glycemic profile. Now at the level of sugars that she has, could be a possibility that simple maternal nutrition therapy can also help.
Yes.
I think with basic counseling, good nutrition therapy. Now also, madam, I think one of the senior doctors made a very important point. I think she works in the rural setup where you cannot tell a patient this much carbohydrate, this much protein, this much fat. They'll say, kya bol rahe? So the most important thing is to have a team approach. Get a nutritionist on board who can help this patient eat this, eat this, eat this. Make a diet. She is least bothered what carbohydrates, what proteins. If we can give her a diet.
About all those things and tell the patient,
Yes.
We cannot get the dietitian everywhere. Okay, so we should.
That's of course.
Yes.
So it is very, it is very easy to identify yourself with the diet that make the patient identify herself with the diet that she eats. But telling her to eat something specific may not be within her reach. So if you ask her, spend some more time, see what she's having throughout the day, and then giving her suggestions how to split those meals, how to make portions and have it throughout the day. And secondly, at 12 weeks, I think with a sugar of 160, good nutritional therapy with the metformin will give you some time for you to start insulin, and that time can be utilized as a time to counsel her and make her readily accept the need of insulin, because it may come a little later.
Yes, I agree.
I'm just little surprised that she's 39 years, BMI 32. It's an IVF pregnancy. How come OGTT is done only at 12 weeks?
Exactly.
Mostly a beta HCG at 14 days after the transfer, and then we'll be behind her even earlier, right? So
absolutely.
Once the beta HCG is positive,
you're not going to be seeing her at 12 weeks. You're going to be seeing her much earlier.
Dr. Deepa, just I think we should not have crosstalk because the audience will not be able to understand. Let us give one take-home message at a time. And Dr. Anjali, you want to say something?
I said no. This IVF pregnancy. So once the beta HCG become positive.
That's the time when you need to screen her.
That is once the gestational sac inside the uterine cavity is seen, even before the fetus is formed, you have to do the diagnostic test.
Yes.
Okay.
And so early diagnosis is important. That patient has already been with us. If she's having impaired glucose tolerance, we'll already be knowing. And yes, for this patient, we were talking of is more challenges if you're expecting in the IVF patient could be hypertensive disorders of pregnancy, could be one, which is one. And then, of course, we have already talked about starting aspirin for this patients. That's what I think what we wanted to add in this patient. Okay. So now this patient is with us, and she's been 1 minute. I'm not able to see.
Under control.
Yeah, 32 weeks. Strict diet. Sugars are in the target range, but blood pressure is 150/100 for us. Scan shows the growth SGA. Now, what next, Dr. Aarti? Dr. Aarti is there?
Yes, ma'am.
Yes,
We go with the urine albumin measurement, ma'am. We'll have to decide whether it's pregnancy-induced hypertension or it is preeclampsia. And then the patients who are just having diabetes, gestational diabetes, there is a 3 times increased risk of sudden death, sudden fetal death. But with diabetes with hypertension, the risk of sudden fetal death is about 7 times increased. So we'll have to be very careful. So we'll have to control the blood pressure also. We'll have to ask her for a salt restricted diet, and labetalol can be used, and we'll have to do her Doppler studies, and with control of the sugar, we'll have to see how the baby, is the baby small for gestational age, and whether there is how is the umbilical artery flow, how is the how is the middle cerebral artery flow, and the cerebroplacental ratio we'll have to see, and weekly we'll have to follow up the patient so that we deliver at the best time.
Dr. Aarti, I think we are talking about clinical, biochemical, and biophysical. All 3 types of monitoring in this patient will be needed. Clinically, we'll have to, we definitely will have to admit this patient, monitor and find out really what we do in our setup, 4 to 6 hourly blood pressure monitoring. We do the biochemical parameters, the renal, which end organ damage, if it is there, then we'll have to find out. And of course, the Doppler study, these are the biophysical studies, which will tell us about the fetal parameters, which if they are affected, and accordingly, based on the what findings we have, we need to decide whether this patient is going to need any antihypertensive, and when to deliver this patient. The Government of India guidelines, I'm going to show you in the next slide. About when to deliver, and these are at or after 39 weeks. If it is well controlled GDM, individualized. If there is a poor control, if there is an hypertensive desired as a pregnancy, if there's a previous history of IUFD, you think that early induction is needed, then individualize. What is the glycemic control? In fact, depending on that, you'll have to individualize. And mode of delivery, of course, again, it is, you have to really look into all the parameters and decide whether you want to really go for a vaginal delivery for the patient. If it's a fetal macrosomia is there, then there is a challenges of shoulder dystocia. And if of course above 4 kg, that is not Indian standards. I think even 3.5, 3.7 kg, we would consider it as macrosomic as far as Indian standards are concerned. Dr. Anjalakshi, your expert comments, please.
See, this patient at 32 weeks, she has a hypertension plus organ involvement. That is, she has gone in for IUGR. So we have to monitor, we have to admit and do the glycemic control, everything, and do the Doppler once in a week, if necessary, even once in 3 days, and give her a steroid prophylaxis and deliver her 1 week. That is, in case of previous IUD, 1 week before the risk period, you should deliver her. Okay. Yes, otherwise, you deliver her at the optimum time. That is, give the maximum intrauterine life and deliver at the optimum time with the Doppler changes indicated.
Yes, if there is a reversal, then definitely we have to deliver. So the absent flow, reversal flow, individualize the care, and accordingly we need to deliver. So because
Madam, can I ask a question, please?
Yeah, Dr. Mithun. To Dr. Anjalakshi.
Yes, to Madam, yes. Because Madam has got vast experience. I have been reading these Government of India guidelines. They say that I'm only speaking about the first, that is at or after 39 weeks. After seeing so many patients, I feel the most feared complication is a sudden death, which happens mostly after around 35 to 37 weeks. So do you still advocate keeping these patients till 39 weeks?
See, in a GDM, when the glycemia is well controlled with the diet and the exercise, you can wait up to the onset of labor.
Correct.
Okay, wait up to the onset of labor. Unless there is any obstetric indication, it is not an indication for cesarean. She can deliver vaginally. Only thing, a senior obstetrician should be there, anticipating shoulder dystocia should be there. In
and 35 to 36 weeks is not the gestation at which we need to terminate, because the lung maturity is not achieved earlier. So even at 38 weeks, we have to be skeptical of delivering. So beyond 38 weeks only, it would be safer for these babies.
Patients who are on insulin, insulin well controlled, you can wait up to 39 weeks.
Okay. Patients who are on insulin but with poor compliance, you have to deliver them at 38 weeks because most of the IUDs are seen in the later weeks. So we have to deliver them. But one thing, I just forgot. You give the steroid prophylaxis. Okay, so that is the important thing. When you want to deliver before 39 weeks, if it is 37 weeks, preeclampsia is there, 37 weeks or 38 weeks, then you have to give a steroid and deliver. So steroid definitely gives a very good outcome, fetal outcome. The perinatal outcome is very good when you give a steroid, timely steroid, not a delayed one. Okay.
Okay, so now this patient comes in labor. Dr. Geeta is not there.
Fine, yeah.
So when Deepa can take this question,
It will leave
37
at
weeks
7. Leave at 7,
intrapartum
10.
management, neonatal complications, how to prevent and how to. We
We
want to be very brief here because the intrapartum management itself is a big chapter. I
What if
think.
there was a delivery?
Yes.
We have to go back.
Deepa, you would like to take this question?
Yeah,
Intrapartum management and bleeding.
she has come in labor preterm.
Dr. Surekha, am I audible?
Yeah, Geeta is there. Yeah, please go ahead.
Okay.
Geeta is there.
Fine.
Yeah.
You are asking about the intrapartum neonatal complications, no?
Yes. Please go ahead. I couldn't see you. Yes, please go ahead.
Sorry, just now I am free. These babies are prone for hypoglycemia, hypothermia, hyperbilirubinemia, polycythemia.
RDS, very important.
RDS.
And come in preterm labor. First thing I would give is a steroid.
Am I audible, ma'am?
He's not.
Dr. Geeta would like to take this question. And we are talking of a patient who is coming at 37 weeks. What would you do as intrapartum management? Because she's coming at 37 weeks.
Weeks admitted in labor, intrapartum management, we have to maintain the target blood glucose values below 100 gram. And when patient is on labor, we have to check the adequate hydration is there. If induced, we have to give the previous day insulin. Morning dose insulin we have to cut off.
Yes.
And every hour we have to check blood glucose levels. With the glucometer, it's enough, more than enough to check with the glucometer and adjust the insulin dosage according to the blood glucose values, ma'am.
Yeah. Dr. Anjalakshi, please, we want your expert comments.
During intrapartum period, again, the strict blood sugar control is very, very important because during intrapartum period, the problems can come like acidosis, electrolyte imbalance that can result in intrapartum death. If you control her during the antenatal period very well and leave it loose during intrapartum period, there is a likelihood of losing the baby. So very strict blood sugar control is very important, keeping it around 100 to 120 milligram%. And every hour blood sugar monitoring should be done. If necessary, you have to give a insulin infusion. So we call it as glucose monitored insulin infusion. That's what we have to give. Every hour you have to, till she delivers, you have to maintain the blood sugar between 100 to 120. And a senior obstetrician team of person should be there, like a senior obstetrician, a pediatrician, a nurse. So you should have adequate help. And you anticipate shoulder dystocia. Okay. And after delivery, you have to sometimes help her out with the forceps. Then after delivery, give the baby
electronic
to the
fetal monitoring, I think in this patient is required.
Yes, if facilities are available, you do a continuous electronic monitoring.
Fetal
Otherwise,
monitoring.
even with the fetoscope, after every contraction, you can monitor the fetal heart. Okay.
Yes, but if you do have the CTG available with you, you should go ahead with do the continuous electronic fetal monitoring for this patient. Keep patient hydrated, and I think one-to-one care is required in this patient. You cannot leave this patient alone in labor. She has to be monitored well, and if there is any problem with the dip in fetal heart or any other indication of fetal hypoxia, you should be very alert, and there should be a low threshold as far as for cesarean section if you detect any
I'm very
hypoxia
sorry
in
to
this
interrupt,
patient.
Dr. Surekha, madam.
Yeah,
but because the technical team has suggested some time constraints, so we have to go.
Yeah. Dr. Mithun? What about
one
the
second.
early delivery benefits versus risk? Quickly, I think we can go ahead.
Yes, madam.
Yes. So what do you think about early delivery? Like you said previously also, can we go ahead till 39 weeks? Should we, what are the benefits versus risks?
I personally believe that unless the benefits outweigh the risk, I wouldn't take that call, because we have to definitely avoid iatrogenic prematurity. Because it's very easy to deliver the baby early, but then when we realize that we can maybe have a baby, losing a baby because of RDS, it could be a simple decision gone wrong. So I feel that sticking to adhering to guidelines and also mixing it with a little bit of experience, anytime we feel that the patient has got any added risk factor other than the controlled diabetes, then you can consider delivering it as per that added risk. Otherwise, I would say that if it's a well-controlled diabetes, go on with the regular guideline, take them till 38, 39 weeks and then deliver them.
Okay, Dr. Vanita, vaginal delivery versus C-section. What's your opinion? When to do a vaginal delivery, whether you want to go with C-section for all babies?
C-section only for offsetting indications and for macrosomia babies, that too, more than 4 to 4.5 kgs. Otherwise, only vaginal delivery will allow.
So individualize, say, look at the patient completely holistically. Any obstetric indications, any additional comorbidities? Do you think the baby is at risk? Risk of hypoxia? Then I think these are the patients which you can go. And of course, macrosomic babies, these are the indications. Otherwise, vaginal delivery is not contraindicated in patients of gestational diabetes, and they should be allowed to go into labor if there is a good glycemic control, as Dr. Anjalakshmi has already talked about. Any practical tips for the third stage you want to add, Dr. Deepa?
She is a patient with who is at high risk for a lot of complications in the third stage. Can be atonic postpartum hemorrhage, can be traumatic postpartum hemorrhage because of a large baby. She can have tears, and if you're going to do a instrumental delivery or a vacuum, there is always a chance that she can go have a shoulder dystocia. So we have to anticipate a lot of problems in this patient, have a complete team ready. I think it's more of a multidisciplinary and teamwork. The pediatrician should also be present. There should be a separate team to attend to the mother as well as a separate team to attend to the baby, because you can't be attending to both of them. And we have to take all precautions to do active management of the third stage of labor to prevent a postpartum hemorrhage and to prevent tears, perineal tears or whatever. And we also have
be
to be
alert,
aware
anticipate,
that they are more at,
prevent, and manage. Is that it?
They are also more at risk of sepsis. So that way, if she has a PROM or something, give her antibiotic and then look out for thromboembolism also in the immediate postpartum period.
That's very important, I think, in the post-op.
Adequate hydration is very important to prevent thromboembolism, and look out for sepsis and look out for postpartum hemorrhage, also birth injuries both to the baby as well as the mother. So,
okay.
And of course, the baby is going to be admitted and taken care of by the pediatrician in the immediate newborn period.
So the baby needs to be observed, I think, by the pediatrician at least for the initial few hours, and then be decided. And of course, we need to. What about Dr. Archana, the postpartum follow-up of this patient, breastfeeding and all? Advice? How do you go about that?
Breastfeeding should be encouraged. She should be encouraged to breastfeed her baby. There is no indication for not breastfeeding her baby. Regarding the insulin or the oral hypoglycemic agents, their need will come down soon after delivery. So we recheck the sugars and give the dose accordingly, reduce the dose. And if it's only a hypoglycemia of pregnancy, most of the times it may even normalize after her delivery. So we'd have to check her sugars once again at 6 weeks postpartum, just not leave it alone that it has come back to normal. So we do recheck it at 6 weeks postpartum, then at 6 months, and then yearly. The follow-up is very important because there is a percentage of these women, up to 20 to 30% of these women, who can become diabetics in future.
So 6 weeks later, we need to do the check the blood sugar alone. Breastfeeding actually is very important. That is going to prevent the hypoglycemia in these neonates. So it's very important that you the early breastfeeding is encouraged in these patients. So very important. Insulin requirement actually may be nil even in these patients, they may not require any insulin at all if she is a gestational diabetes mellitus. These are the take home. Thank you, Dr. Archana. Dr. Emmanuel, any fertility issues in this patient in the next pregnancy? And what would you advise, about the next pregnancy, how early or late? Dr. Emmanuel is there? I can't see him.
I don't think.
Think so. So he was driving. So basically, I think if these patients usually have certain fertility issues, and if they want to conceive, maybe after they should be in. Yes. Yeah. Please go ahead.
The most important thing is for them to not feel that they have to maintain their sugars post their delivery. So a lot of patients, we keep harping on them that it's gestational diabetes. We lose them on follow-up because they think it is just gestational and then to not follow up. Adequate spacing is important. And of course, before they try for their next pregnancy, another gold standard would be to do a HbA1c, because it will tell us what she has been up to for the last 3 months before she is thinking about her next pregnancy. So counseling, I think, is very important to make them understand that the sugar story is not over after the baby is out. It could be that we might have diagnosed it as gestational diabetes, but she must have been over diabetes picked up in pregnancy or something like that.
So, yes. So these things I think we have already covered. And again, we are reiterating about the preconceptional counseling in these patients. And after maybe adequate spacing, she should, if she wants the second baby, then she should consider it early than late.
After the HbA1c.
Right. So long-term consequences of GDM and how to follow up, Dr. Aarti.
Unmute, ma. Unmute.
Yeah.
20 to 30% of the patients, they go for diabetes mellitus in about 1 or 2 decades. So we'll have to check on the 3rd postpartum day, we'll do the sugars, and then as madam told, after 6 weeks, and then every yearly, and we'll have to tell them to maintain a good BMI and regular diet and exercise.
So once these patients are having gestational diabetes, in the follow-up, you're finding that these patients have again chances of having over diabetes later on in their life. They even may have cardiovascular other problems also in these patients. So because the risk factors are existing in these patients, the one of them is the high BMI, the carbohydrate, the type of diet they are taking, the ethnicity. All these are high-risk factors which are going to lead to all these complications. Dr. Anjit Lukshi, your last word on this.
Okay. In the postpartum period, the lactation is very important because the breast milk is programmed as for the babies, GDM babies, so that the mother will not have obesity as well as the baby will not develop a childhood obesity. So it is very important. They have to breastfeed exclusively. If not possible, at least whatever time possible, even a small duration will benefit both the mother and the child. One. And regarding the insulin requirement, once the placenta is delivered, all anti-insulin hormones will go up, the requirement will come down. So you have to closely monitor, and if the patient is taking insulin already, we may have to stop. If it is an operative delivery, we have to keep the target value of 150 milligram. If it goes beyond that, you have to give them some amount of insulin to control. So your target value should be 150 so that the healing will not be hindered. Okay. Next is regarding the postpartum follow-up. 6 weeks we say, 6 to 12 weeks we say, but that is not possible. Practically we are missing lot of cases. We are not following up. So it is better to follow them when they are in the hospital itself. That is 3 days after delivery. You can do a fasting PP blood sugar. Also, you can do a single DIPSI test. You can do the DIPSI test and find out whether she will have the intolerance or she will go to a diabetic state and all. You can monitor, and by the way, you can keep them under your nose.
Okay, madam.
Leaving them 6 weeks. You do the DIPSI test on the 3rd day in the postnatal ward, in the postoperative ward. 3rd day, we allow a normal food. So you can do a DIPSI test and then categorize them and keep them under your care.
So definitely this patient is going to need a long-term follow-up with you, and she's your patient, and she's going to come to you later on also for contraceptive advice. So what we have to keep on telling them is about, yes, Dr. Emmanuel, if you want to add, otherwise I would like to conclude here.
Anjalakshmi ma'am, I want to tell one point. In government hospitals, we do fasting and postprandial blood sugar after 48 hours after delivery in postnatal ward.
Do
And
it
ask them
after
to
a
come up.
challenge. Do it, Geeta, do it after a challenge,
Yes.
and give us the data. Okay. So we are working on that actually. In
Which is ideal,
KGH
ma'am?
and IOG, we are working on that. So you give the
Okay,
data,
ma'am.
no, we can compile and we can publish.
Okay.
Yes, ma'am.
Yes, so what I wanted to add to it is that this patient is going to be in your follow-up. You have to keep on advising her about her diet, exercise. Then you have to advise her that yes, there are chances of in future she may become over diabetic. So regular follow-up of this patient, and education, awareness you have to keep on, because she's your patient, she's going to listen to you. So that is what I think it's very important, and what the panel has told us, that early detection, careful monitoring and treatment of this patient is going to give us a good result in our patient. So thank you very much, all the esteemed panelists.
Sureka, the last word. See, previously we used to call GDM as a forerunner of type 2 diabetes. Now we have to call it as a forerunner of NCD, non-communicable disease, diabetes, dyslipidemia, cardiac disease, all those things. Okay.
Right.
And Dr. Usha Sriram used to tell the GDM is a hanging fruit. You have to just pluck it and eat it. So you have to look for the GDM and treat, so that you can prevent at least diabetes in the offspring. Okay.
Right, ma'am. Absolutely. And wonderful. I think the panel was, all the esteemed panelists have given really good take-home messages. And Dr. Anjalakshi being with us, I think we ourselves have been updated on this, as even we are faculty, the panelists, but we still have learned a lot from you, madam. And thank you very much, all the esteemed panelists, for being with us and sharing your knowledge. And I'm sure that the viewers are hugely benefited from this whole session of the lectures as followed by panel. So thank you very much, Dr. Rashmi, for your vote of thanks.
Dr. Sureka, what I told you is correct, no? Regarding
Yes,
Anjalakshmi,
definitely. And everything Dr. Sampath Kumari talks about, I think we have to go and read the recording again and again and follow up in practice. Thank you very much, Dr. Sampath Kumari, Dr. Anjalakshi, Aarti, then we have Deepa, Vanita,
Thank you all,
Geeta.
madam. You made us to
It was a
read
wonderful
again.
And
panel.
Mikun and Emmanuel, I think those were the icing on the cake. So we brought them from Goa and to Tamil Nadu, and really they enriched us with their knowledge. So Rashmi?
It's actually a wonderful panel. I think Dr. Anjalakshi madam has verbatim, she has told elaborately the management of diabetes.
Yes,
the talks were absolutely nice, and Sampath madam also gave a very nice talk. Very nice to be in this program today. Thanks, Dr. Sureka.
Thank you. Rashmi?
Thank
you very much. The webinar was presented in association with Corona Remedies, COR Connect. We are very much thankful to Vasu sir and Abhishek Shah and Nisha Thakur for the excellent cooperation and coordination. Thank you, Corona Remedies. Thank you all the participants. I must say that 216, about 260 audience were logged into today's webinar. Thank you so much.
So that is an achievement in itself, because
that's great.
nowadays the webinars are going very thin. So thank you very much, and see you again in our next meeting. Thank you, everybody. Have a good
wishes for your
dinner.
effort.
Thank you. So yes, I have to make my appeal also, no? Please vote for me for Clinical Research Committee.
Yes, Dr. Surekha Taide is an ideal candidate for the chairperson of Medical Research Committee, and I request all of you, all the friends, to kindly vote for her, and let's see her as the chairperson of Committee of Clinical Research.
Thank you very much, Rashmi, and have a great dinner with your family. Thank you so much.
Thank you so much.
Bye.
Thank you. Thank you, ma'am.
Thank you.
Thank you.